welcome to you, sir. Dr. L. Vijaya, Distinguished Senior Consultant, Glaucoma Services, Shankar Nethralaya, past President of the Glaucoma Society of India. Madam has been my mentor, my teacher, and guide in the Glaucoma Society for the past almost 2 decades. She is the motivation behind the Hooghly River Glaucoma Study. She sent me the methodology of the Chennai Glaucoma Study, and the Hooghly River Glaucoma Study is built on those lines. I was lucky to organize the Kolkata Glaucoma Society meet in 2007 under her able leadership when she was the president. And we did have a lot of good times then, and Madam guided us at every step. Thank you, Madam, for accepting our invitation, and welcome this evening. At the table, decisions and choices, we start with our speakers. Dr. Shirisha Senthil received the Best Scientific Paper Award at the Glaucoma Society meeting in 2007. And then you can see all those years that she has received the Best Video Award, and at the WGC as well in 2015. She specializes in managing refractory adult and pediatric glaucoma. Other areas of interest are glaucoma drainage implants and managing combined cataract and glaucoma. She is the head of VSC Center for Glaucoma Care at the LBPI Hyderabad. The very warm Dr. Professor Sharma, Senior. Dr. Prafulla and I go back many, many moons, right up to our college days. And thank you for accepting our invitation, and a very warm welcome to you. Dr. Ganesh B. Raman, Fellowship in Glaucoma at the Aravind Eye Hospital, Coimbatore, Chief Glaucoma Services, Aravind Eye Hospital, Coimbatore. A very warm welcome to you. Dr. Sathi Devi heads the Glaucoma Services at Narayan Nethralaya 1 in Bangalore. Trained at the Shankar Nethralaya, she has been in exclusive glaucoma practice for close to 25 years now. A very warm welcome to you. Dr. Shushmita Kaushik, Professor Glaucoma Services at Advanced Eye Center, Postgraduate Institute and Medical Education and Research, Chandigarh, has 120 publications in reputed indexed international and national journals, and has contributed 32 chapters to various textbooks. Authored the glaucoma section of Datta's Modern Ophthalmology, Textbook of Ophthalmology, and OCT Colored Atlas. Founder Secretary of the Indian Pediatric Glaucoma Society and former Secretary of the Glaucoma Society of India. She is a co-author, Consensus Guidelines on Childhood Glaucoma of the World Glaucoma Association. A very warm welcome to you, Dr. Shushmita. Dr. Sunita Dubey did her fellowship in glaucoma at the Wills Eye Hospital, past treasurer of the Glaucoma Society of India, head glaucoma services, medical superintendent, head of quality assurance at the Shroff's Charity Eye Hospital, New Delhi. Recently gained good experience in performing minimally invasive glaucoma surgeries. A very warm welcome to you, Dr. Sunita. Dr. Anil Mandal, lovingly known to us as Anilda, hails from Kolkata and has been working at the LV Prasad Eye Institute for the last 30 years. His specific area of interest is pediatric glaucoma and has treated over 3,000 cases in pediatric glaucoma. He has published over 150 papers. He is the recipient of the prestigious Santi Roop Bhatnagar Award for his clinical genetic and research work on pediatric glaucoma, and has been honored by the American Academy of Ophthalmology. A very warm welcome to you, Dr. Mandal. Dr. Devin Tuli, Consultant Glaucoma, Delhi. A very warm welcome to you, Dr. Tuli. Dr. Lipi Chakravarti did her glaucoma fellowship and been glaucoma consultant at Aravind Eye Hospital, Madurai. She is presently running her independent eye center, Lipika Netradham, Associate Professor at CCM Medical College, Chhattisgarh. A very warm welcome to you. Dr. Manish Pandey, Director Glaucoma, Ratan Jyoti Nethralaya, Gwalior, former consultant at the Glaucoma Services of Shankar Nethralaya, Chennai. A very warm welcome to you. Dr. Maria Mansouri, Professor of Ophthalmology, M&J Institute, Civil Hospital, Ahmedabad. A very warm welcome to you. Dr. Sailaja Sengupta, Glaucoma Fellowship from LVPI Hyderabad, Specialist at Sanjeevan Hospital, Kolkata. A very warm welcome to you. Dr. Amit Parwal, Senior Consultant, Cataract and Head Glaucoma Services, Chotiram Nethralaya, Indore. Member Scientific Committee, the AIOS. Central Zone Executive Committee Member, Glaucoma Society of India. Chairman, Scientific Committee of the MP Chapter. And Clinical Secretary, Indore Divisional Ophthalmological Society. A very warm welcome to you. Dr. Parul Ichhapurani, Associate Professor at the Government Medical College and Hospital, Chandigarh, a clinician and academician, author and editor, currently member of the Education Committee and Associate Advisory Board, World Glaucoma Association. A very warm welcome to you. Dr. Manju Pillai has been actively involved in patient care, training and teaching postgraduates and ophthalmologists in the specialty of glaucoma. She has been an invited faculty at the TNOA and the Glaucoma Society of India. Medical consultant, glaucoma services, Aravind Eye Hospital, Madurai. A very warm welcome to you, Dr. Manju. Dr. Swati Upadhyay, DNB from Aravind Eye Hospital, Pondicherry, then did glaucoma fellowship, following which she joined there as a consultant. Areas of interest are MIGS for developing countries, has been performing GAT and Trabecto for past 1.5 years. A very warm welcome to you, Dr. Swati. Dr. Reena Chaudhary, fellowship from Shankar Netralaya, working in the field of glaucoma and cataract since last 20 years at the Eye Care Hospital, New Delhi and PG Institute. Presently the Director of Glaucoma Services, active speaker at many national and international conferences and has published many papers in peer-reviewed journals, numerous chapters for textbooks and authored a book on interpretation of visual fields. Part of national and international glaucoma clinical trials. A very warm welcome to you. Dr. Shubhas Prasad, Director of Eye Center, Patna, has been trained at the Art Center in New Delhi. Also,
audio is not clear.
Assistant Professor.
Yeah.
Sorry, there was a network problem. So Dr. Devashish Chakraborty, Fellowship in Glaucoma from the LVPI Hyderabad, currently associated with Center for Sight Kolkata, has been practicing glaucoma and cataract for the past 13 years. A very warm welcome to you, Dr. Devashish. Dr. Tutul Chakraborty, a clinician and a clinical researcher in the field of glaucoma. She is a 2019-20 Fulbright Research Fellowship awardee affiliated to the Hamilton Glaucoma Center at the University of California, San Diego. She has been working on central visual field defect in early glaucoma as a principal investigator. Very warm welcome to you. Dr. Anuradha Chandra, Chief Consultant, Pediatric Ophthalmology and Strabismus, Neuro-Ophthalmology, Shushruta Eye Foundation and Research Center, Kolkata, MS in Ophthalmology from RIO, Kolkata, followed by training at the RP Center, Assistant Editor of the Bengal Ophthalmic Journal, Project Head of Orbis India at Shushrut, AIOS ARC Educator, and a faculty speaker with multiple publications. A very warm welcome to you. Dr. Ravindran T, Fellowship in Glaucoma from the Aravind Eye Hospital, Tirunelveli, Head of Department of Anterior Segment, FACO and Glaucoma Services at Vishakhapatnam in his own eye hospital. Thank you very much. With that, we move on to the first keynote speaker, Dr. Ramakrishnan. I just stopped sharing my screen. Thank you very much. Sir, you can start sharing your screen.
Are you able to see the screen?
Yes, sir.
Okay. Good evening to all my friends, and at the outset, I'd like to thank Calcutta Academy of Ophthalmology, especially Dr. Chaudhary, Chandrima, and Smith for their wonderful arrangement of this webinar, the galaxy of speakers. And of course, I have been asked to talk about childhood glaucoma in the next 15 minutes. All of you know very well it's a very, very vast subject. I will just go through some of the important aspects about the aerial view of the childhood glaucoma. It's a worldwide disease, and 15% of the childhood blindness is due to glaucoma in the children. And of course, the impact on visual function is very serious when compared to adult glaucoma. And of course, most 99% of the glaucoma, pediatric childhood glaucoma is surgical, only surgery only. And what is childhood glaucoma? Childhood is a definition is according in US it's almost 18 years and less than 18 years, and in Europe it is 16 years. But usually, normally, we consider childhood glaucoma anything which is less than 18 years of age in our situation. There are so many classifications have been put forward to classify this galaxy of conditions like Hoskins, Schaffer, Covington classification. I'm not going to detail about that. Tubercular dysgenesis and iododysgenesis and all these things. And one of the latest, the well accepted and very easy to follow is the childhood glaucoma research network classification. That is, we can divide them into primary childhood glaucoma and secondary childhood glaucoma. In primary, you will have all these primary congenital glaucoma of infantile or neonatal or juvenile open glaucoma. And secondary, you can again divide them into two groups. One is associated with congenital developmental glaucoma associated with some ocular or systemic disorders, or with some other secondary cause like trauma or cataract surgery or uveitis or tumors, something like that. And juvenile glaucoma is similar to open glaucoma, except there is no other anomalies or syndromes. Angle is very well open and meets all glaucoma definition, and no ocular enlargement, no other congenital defect. And of course, the primary congenital glaucoma is again is child glaucoma. 20% of them constitute about mainly because of the primary congenital glaucoma of early onset within 3 years of age. And other 47% is developmental glaucoma, tubercular dysgenesis or vacuomatosis and other conditions constitute about 47%. And close to 30% they are from post-cataract or post-inflammatory intraocular tumors and uveitis. All these constitute about 28% of the cases. Primary, I'm not going to detail about that. All of you know very well. It's within any glaucoma within the 3 years of age, you will have ocular enlargement because the sclera is so much elastic in the first 3 years of age. After 3 years, suppose a child develops glaucoma after 3 years of age, you will have anterior-posterior elongation because posterior sclera is elastic, so you will have axial myopia and then glaucoma. These are the trade-off symptoms, epiphora and all these things, and all these changes. I'm not going to detail about all these things. And other group of child glaucoma is your antechamber cleavage syndrome. That is Axenfeld-Rieger's anomaly and syndrome. So this one is just a prominent posterior embrotoxin. What you are seeing, white line in the posterior surface of the cornea, is it may be associated with maybe a congenital anomaly. It can be associated with the glaucoma. And the second thing is you will have what you call as the Rieger's, Axenfeld-Rieger's anomaly and syndrome. Anomaly is just a polychoria and correctopia, iris atrophy, and all these things. With glaucoma, it is a syndrome. Then the third thing is central, only it involves the central aspect of the cornea. There's a posterior corneal opacity with defect in the endothelium and descemet membrane with the strand of iris attached to the back of the defect and glaucoma. If it is associated with some systemic anomaly like mental retardation or hypothyroidism, then it is called the Peter plus syndrome. And then another important, which is a devastating disease, is the aniridia, which is very, very difficult to manage. It's close to 30% of the children with aniridia will have a glaucoma. And the etiology and the types of aniridia and all these things are entirely a different topic. Then a major group of glaucoma from congenital hypoplasia of the collagen tissue as Marfan syndrome. All these systemic features, the elongated, long, slender fingers, and all these thumb signs and wrist sign, and you will have ectopia lendis. And glaucoma is about 20 to 30% of the cases will have a glaucoma. Then another type of plastic collagen disorder is the wheel Marcasani, where we have a stunted growth and stumpy fingers. and you will have a microsphere of phakia. There's a lens will be spherical, anteposterior length of the lens will be more, and the lens will be almost like a ball. So it is a wandering lens. It can wander from antechamber to posterior chamber, something like that. So one of the important blocks, so you should be able to early and treat them early. And syndrome is a glaucoma, lentis, and microspherophobia, stiffness, and then another group is your phacomatoses. Almost some of the not will be associated with glaucoma. Commonly, it's associated with usually unilateral, mainly because of the rise episode. There is a upper lid enlargement. You will have hemangioma. We have to look for the rise intraocular pressure. Suppose a child develops glaucoma within life, then they will develop what you call second ophthalmos. The eyeball will be almost like ophthalmic eye, and then management is mainly surgical only. Then the second phacomatoses is where ocular double melanomas of vota. This glaucoma is very common, very easy to treat, mainly surgical only. Here everything will be pigmented, conjunctiva, sclera, cornea, iris, angle. Angle look as though it's painted with black. So that's type of glaucoma. Then this is a very rare condition. It's tuberous sclerosis. We have ectropy and UVA and angle closure glaucoma because of the zipping of the angle. Then coming to the management, no, I'm not going to talk about management detail because Dr. Susmita is going to talk in step by step. So mainly, it's one of the challenging problems in the field of ophthalmology because there are so many challenges because of poor cooperation and long-term follow-up, lifelong follow-up, and ocular disease itself is very much different from adult. And associated other ocular and systemic comorbidity, they will have a systemic problem of cardiovascular or CNS. All these problems are common with this type of glaucoma. And also, they may need a frequent examination and anesthesia depending upon the age of the children and the difficulty in managing these are the various challenges. Complete, thorough examination and anesthesia is very, very important to know about all these things like cornea. You have to assess the cornea, and of course, refraction. You have to do a corneal diameter and look for the corneal clarity. Intraocular pressure measurement by either Pen or Perkins is ideal. Then, of course, detailed fundus examination, fundus photo if possible, we can take. The retinoscopy in each and every visit. If there is really clear, we can do a retinoscopy. Then, ultrasonography and corneal phacometry is very, very important to see the progression of the disease. We have to do a series of ultrasound to look at the axial length of the child. Then, of course, another important thing is the anesthetist who is giving anesthesia for this type of cases should be well versed with the pediatric anesthesia because he should play a major role in these cases, and he should have a basic knowledge about the congenital glaucoma and other problems. And also anesthetic drugs, also we should be familiar with what are the drugs that can be given during surgery, especially use non-depolarizing muscle relaxant like vacuronium bromide, and always are better to avoid depolarizing muscle like succinylcholine. And laryngeal mask airway is preferable, and doing sudden rise in intraocular sometimes it may happen. Definitely it will hamper you during surgery. So we have to instruct the anesthetist. We must have a soft eye during surgery. Then, of course, coming to the management is mainly a surgical disease, but medical management has got a very poor, very minimal role in like a supportive role just to control the intraocular pressure before a surgery, and the post-operative also. Suppose the child has got a rise in intraocular procedure has failed, we can start them on medical treatment. And of course, in high-risk patients where you are not able to do surgical management, then we have to the medical treatment. Various like adults, we have all the anti-glaucoma medication. But one thing is, two things I want to emphasize here. One thing is better avoid or not avoid. Strictly contraindicated. It's alpha agonist in children less than 10 years. And of course, punctal occlusion, we have to teach the parents to occlude the punctum whenever they apply so that we can minimize the systemic absorption, so that we can minimize the systemic side effects because of the topical drugs. And timolol is a safe drug, especially in children, but in cases with some respiratory problems, then it's better to avoid. And of course, we don't have a lesser concentration. Previously, we had 0.5, but it's not available. But recently, they have introduced 0.1% timolol, which is mainly for neonates and infants. And the beta-oxalol is very well safe, this 0.5 and 0.5%. Then, of course, carbonic anhydrase inhibitors are well tolerated in children. And acetozolamide, you can give orally the dose of 10 to 15 milligram per kilogram body weight in the divided doses. Of course, the two available topical carbonic anhydrase inhibitor, dorzolamide and birzolamide, can be very well used. Birzolamide is much more user-friendly than the dorzolamide drops. Latopraz is less efficacious in children, and the combination also is both as monotherapy as well as combination therapy. As I mentioned, is definitely contraindicated. And of course, the goal of the recent one, ROCK inhibitors, people have started using ROCK inhibitors in pediatric glaucoma. Still, we have to wait for the research. The goal of surgery is to preserve the vision and also to preserve the ocular integrity and quality of life of the children. And of course, the plan, we have to plan the surgical approach according to the patient presentation and the experience of our surgical experience and our equipment availability, etc. These are the various arena of surgical options available for surgical glaucoma, starting from goniotomy to the cyclodystrectomy procedure and the setons. And of course, in Indian scenario where most of the cases of congenital glaucoma come with a very advanced stage, with advanced corneal enlargement and the corneal edema. Both the combination of trabeculotomy with the trabeculectomy is an ideal procedure where we have a very good success rate in these type of cases. This is a case, just a patient presented with nevus all over the body with bilateral congenital glaucoma. It's a cutis marmerata telangiectasia with the congenital glaucoma, bilateral. So we did all the imaging, CNS, and all these imaging we done, and nothing, everything was normal. This all viscera was normal. CNS, there is no cardiovascular abnormalities. Only cutaneous abnormalities was there. So we go ahead with the this combined trabeculotomy and trabeculectomy, and this is the same case. And this is aniridia. Aniridia also we can use same combined procedure, but we have to be very careful. Because there is no iris to guard the injury to the lens. So we have to do careful when you do we have to do a limited trabeculotomy. We should not injure the lens, and also we should not, because once you injure the lens, then it will become cataract, and chance of vitreous loss also is there. So we should be very, very careful. I am not going to detail about the surgical step. And this is again another case with congenital glaucoma associated with congenital persistent people remembering. So here I did both trabeculotomy with trabeculectomy. Then I removed gently this membrane with vitrectomy scissor. The patient was doing all right, and of course it's a unilateral case. And this is a child I mentioned that cutaneous vascular malformation. This is 4 months after the surgery. Most of the vascular hemangioма, that nevus has disappeared. And this is after 8 months of surgery. The child is almost normal, both the cornea is clear. It's really, so I was very happy after this seeing the child. When I saw the first month, the child was so emaciated, and I was so edematous cornea and with a lot of systemic problems. But now after 8 months, the child was completely, I consulted some of the dermatologists and pediatricians, and they say this type of nevus will automatically clear, especially when you give steroids. It's either orally or even with topical. Here we operate both eyes, so we given steroid for almost 4 to 6 months. That also helped to dissolve this type of cutaneous nevus. Then, of course, this is a Sturge-Weber syndrome where I did primary tube that Barwell's, it's not Barwell's, EJV implant. I'm not going into detail about the surgical procedure. And then, of course, coming to the prognosis of this type of, because I'm not going to touch upon the other secondary glaucoma, post-traumatic, then it will become a very big post-traumatic, uveitic, and traumatic glaucoma is very common, especially traumatic lens-induced glaucoma, traumatic angle recession, traumatic hyphema. All these things are very common in children. And the glaucoma following cataract surgery also, even though the incidence has come down following recent surgical advances, still we are seeing glaucoma following cataract surgery. So the ultimate prognosis depends on the early recognition of this condition, and we have to treat them at the almost immediately with the medical or surgical treatment, whatever suits for the child. And of course, mainly the commitment from the family and the pediatrician is very, very important, because it's not like a cataract surgery where you come and do surgery, because here the patient has to come for follow-up throughout the year, and they may need a frequent examination under anesthesia, etc. And the follow-up, of course, is lifelong, and because increase in intraocular pressure can occur at any time that we have to instruct the patient as well, not the patient, parents will be thoroughly given counseling for this type of this thing. And of course, the other important thing is because we will be all the time concentrating about the other aspect of the management, especially the visual rehabilitation. So this is very, very important, because not only control of intraocular pressure, at the same time simultaneously we have to visually rehabilitate, either by giving glasses, correction of the refractive error. Periodically we have to assess the children, and the correction of anisometry. Most of the glaucomas are unilateral, or even primary conjunctival glaucoma, about 20% of them can have unilateral glaucoma. So in that case, anisometropy is we have to take care. And media opacity, especially in Peters syndrome or say corneal opacity in advanced congenital glaucoma, we have to take care of this opacity, say by doing keratoplasty or any other procedure. And of course, amblyopia therapy is also is very, very important whenever there is necessary. So this is about in short. I have this child glaucoma. So I once again thank the Calcutta Academy of Ophthalmology for arranging and giving this wonderful opportunity. Thank you very much.
Thank you, sir. Thank you very much indeed. That was a really good overview that you gave us of childhood glaucoma, full of interesting pictures and a lot of learning. A very signature talk of you. Thank you very much, sir. With that, we move on to Dr. Vijaya, ma'am.
Yeah.
Ma'am, if you're ready, you can share your screen. Sir.
I think he has to close.
Yeah, just wait a minute. Yeah. I'll do it. Okay. Good, thank you.
Okay, at the outset, I would like to thank Calcutta Ophthalmic Association, Chandraman Rajesh, for arranging this webinar. The topic I have chosen rather is the top points for safe trabeculectomy. The trabeculectomy is still very widely done surgery and gives good control of IOP, but it has many short-term and long-term complications such as leaks, choroidals, hypotony, infection. In spite of this, we are still doing trabeculectomy because there is no ideal substitute for it. So what we can do in such a situation? We can think of some important crucial points that will minimize the possible complications we face with a trabeculectomy. So everybody knows that the major cause for failure of trabeculectomy is excessive healing at the conjunctiva tenens fascia episcleral interface. And And when we do the trabeculectomy, we should have a blood that controls the intraocular pressure, and usually such a blood will look should be a diffuse blood with mild elevation, reduced conjunctival vascularity, presence of the conjunctival epithelial microcyst. How can we achieve such a blood is the challenge. And if you want to achieve such a blood, and the exercise starts with the preoperative evaluation. Then we have to be careful perioperatively also, certain steps will help us. Similarly, it is a post-operative course is very important. Trabeculectomy is a very labor-intensive surgery. If you pay proper attention with all the three phases, we are likely to get an ideal trabeculectomy blood. So, preoperatively, what are we supposed to look for? And pay attention to the ocular history and clinical examination. Somebody is having high myopia, planning to do a trabeculectomy. These eyes are prone for hypotony because of the scleral stretch. So one should use low dose of antimetabolite such as mitomycin C, or you can avoid antimetabolite and go for a collagen matrix such as the Ologel to minimize the hypotony. Routinely, we all use the releasable sutures. It has become part and parcel of the trabeculectomy to modulate the wound in the postoperative period. So we should have a very cautious approach in releasing those sutures. Similarly, at a later part in the postoperative period, when we use the organ laser suture lysis, one has to be extremely cautious. Sudden lowering of the pressure can result in the hypotony. And hyperopia is known to cause some problems, especially if the hyperopia is very high. Evaluate for non-ophthalmus because surgical techniques demands a procedure like sclerectomy to minimize the complications associated with non-ophthalmus. And it is not unusual for one to see a situation like this, a periorbital reaction like this with the prostaglandin analogs, or a giant papillary conjunctivitis with brimonidine group of drugs. So this kind of situation should be identified and taken care well ahead of the surgery to minimize the scarring and increase the success of the trabeculectomy. So pay attention to the ocular surface. Also look for any drug or preservative induced changes. Consider stopping all the topicals if the reaction is quite significant. Use systemic acetazolamide to control the pressure at that time, and this helps in resolving the reaction that patient is having. And certain situations one may have to consider topical steroids to reduce this reaction so that patient will be ready for the surgery. And we all know that angle closures are prone for certain problems like shallow antechamber, they're prone for the flat antechambers, aqueous misdirection. So plan well. Preoperatively give IV mannitol to reduce the volume of the vitreous so that the antechamber forms well following the trabeculectomy. Go for tight releasable sutures so that the antechamber will be found well on the table. And post-operatively, these sutures can be handled one at a time. Use of post-operative atropine is very essential in angle closure glaucomas because it helps in forming the antechamber because it relaxes the lens iris zonal diaphragm. And one word about visual fields. Whenever we do surgery, I think it is mandatory to have a visual field just in the within few months of the examination, and look for any fixation, threat to the fixation, macular splitting. If there is such a situation is there, it is mandatory to remember that these eyes are prone for complications like wipeout if you don't take care of the iopic spike that can happen with the surgery. So preoperatively, you control the pressure well, and post-operatively try to avoid the iopic spike. If needed, keep patient on Diamox for a day or two till the trabeculectomy takes over in controlling the pressure. And coming to the Perioperative, it starts with the anesthesia, and patient safety and comfort is the main goal for giving any anesthesia. Of course, we give the general anesthesia for children and select adult patients where local is contraindicated. Most of the trabeculectomies are done under local anesthesia. We all started with the retrovalvular, moved on to the perivulvar. Now we have come down to subtenon and the topical. So what is the advantage of going down to the subtenon and subtopical? If you look at the retrovalvular block, how it is given, we go into the cone and very close to the optic nerve. So there is always a risk that a compromised optic nerve will get more affected with a retrovalvular block. So under any circumstances, one should not contemplate giving any retrovalvular block. Perivalvular was found to be safe, but even though you don't enter the cone, your periconal area and where you are injecting the anesthetic, the volume, if it is high, there is always a risk that it can cause a compression on the optic nerve head. And sometimes inadvertently, one can enter the cone and cause the damage to the nerve as well. Because of that, people have started moving to the subtenon's injection of the anesthetic, and which is safer and you are far away from the nerve. And it takes away the pain, but akinesia, you may not get it, but reinforcing with some other measure, sedating the patient, the trabeculectomy can be easily done. To get a balance between the two, we tend to do a single injection of the perivulvar in the inferior quadrant with a minimal, maybe 2 to 3 cc, and we reinforce it with the subtenons. And that way patient will be comfortable, and it is a safer practice of anesthesia for a glaucomatous eyes. Consider sedation as a supplement if the patient is not very comfortable with this amount of anesthetic. So trabeculectomy has specified steps, and it starts with a good traction suture. It can be supinarectus or the clear corneal depending upon the surgeon's choice. Conjunctival flap, antimetabolite application, scleral flap, internal ostium, iridectomy, flap closure, and conjunctival closure. Specific steps, it goes like mathematic sum in a particular way. Any mistake anywhere can lead into complications. Fornix based versus the limbus based. Most of us nowadays do the fornix based because it gives a diffuse bleb in contrast to a limbal base. Fornix based flap is technically easier, a better exposure. But remember, any fornix based flap tend to have some amount of postoperative leak that has to be kept in mind. Limbal based flap is technically difficult. It offers tight wound closure, but limbal based flaps have been blamed for giving a very thin localized cystic blebs because of the steel of ring that forms at the incision site. So people have moved away from the limbal based to the fornix based. So conjunctiva should be dissected very carefully. Use non-tooth forceps. Keep conjunctiva moist all the time. Avoid edge contact of the conjunctiva with the antimetabolite. At the end of the surgery, ensure watertight closure. Use a tapered needles to do that, or a round-bodied needle. Size and shape of the scleral flap can vary, but remember, 1/2 of the scleral depth is what is needed. And nowadays we get a depth knives which is 300 and 500 microns. In a normal adult, I think 500 micron depth knife is fine. In high myope or in children, one can consider 300 micron depth knife. It should be uniform lamellar dissection and should be very gentle manipulation to avoid any damage to the scleral flap. Sclerostomy, whenever we do that, you can do it either with a punch or with a Vanna scissor. Ensure the flap overlaps sclerostomy by 1 millimeter in all directions, so that there will not be any overflow of the aqueous and related hypotonia and shallow antechamber. Burying the suture knot helps and increase the postoperative flow by using the releasable sutures. One can consider laser suture lysis. As I mentioned, releasable sutures have become part and parcel of the trabeculectomy. I don't specifically mention them as a separate because It is a part of the trabeculectomy. Coming to the iridectomy, it should be broad, wider, full thickness. Otherwise, a partially cut or a small iridectomy can prolapse in the postoperative period, can block your ostium. So this is just a collage. So you can see here a clean triangular scleral flap. Here it is a limbal based flap and a superior rectus traction suture. And once you dissect, the dissection should be up to the clear cornea. This is the surgical limbus. So please note that it is a very clean, uniform cut. And once that is over, the internal ostium should be sufficient in size, and it should just stop at the junction of the gray and the white. That is the limit of the surgical limbus. And iridectomy should be done with a precision so that you will get a good iridectomy without any tags being left behind. Here is, I tend to do one releasable suture. There are many techniques. You can follow whichever you are comfortable with. And I tend to do a apical releasable suture so that the flow is posterior and you get a diffuse posterior blood. Once that is taken, two apex and base sutures very close to the base so that the flow is directed to the posterior, not to the side, and this will give a good amount of resistance for any side flow of the aqueous, and you will get a posterior diffuse blood with this technique. And once that is over, you should close your conjunctiva with the wing sutures or whichever technique you are comfortable with. Make sure it lies over the limbus and gives a watertight closure. And antechamber should be well formed at the end of the surgery, and the eyeball should be firm and not too hard or not too soft. One way of checking it will be if you press on the center of the cornea with any instrument, you should indent easily with some resistance, but it should not be too easy to cause the indentation. So post-operatively, what to do? When the blood is not ideal, plan some revision. And early blood failure causes are many, but I like to just touch upon three: tight scleral flap closure, conjunctival leaks, serous choroidals as a complication. So tight wound closure reduces complications. We all do that, but nowadays we do it with the releasable sutures. So when there is not enough flow, you apply a little massage on the first day, and after 48 hours to 72 hours, you release one suture. That is, I tend to release the releasable, that apical suture. If somebody is using two sutures, release only one at a time. So with this digital massage and releasing the sutures, when you have used the optimal antimetabolite, most of the times we will be successful in getting good amount of flow, and the blood starts to function, and you will see the cystic changes. Even at a later period, usually after 3 to 4 weeks, sometimes even 6 weeks, I tend to cut the permanent suture using the laser suture lysis, that is the base suture. Laser suture lysis should be done in the window period. That is, if you have not used the antimetabolites, it should be within 2 weeks. If you have used the antimetabolites, it is 6 to 8 weeks, it will be effective. A good exposure of the suture is important when you are cutting the suture. You get that with using any of the lenses. Commonly used lens is the Hoskin lens. And power is a 200 to 300 milliwatts, 0.1 second exposure time, 50 micron spots. Remember to cut one at a time. It can cause some of these complications like a conjunctival burn, subconjunctival hemorrhage, hypotony because of the sudden lowering. Sometimes even hypema can happen. And cut the crucial suture. When it comes to the angle closure, we have a conservative approach because sudden shallowing can cause aqueous misdirection. Similarly, an eye prone for the hypotony, we have a conservative approach. The conjunctival leaks, as I mentioned, with the fornix-based flap, it's more common. When you use the antimetabolites, again, it's more common. Sometimes the leak can be because of the undetected buttonholes during the surgery, or maybe post-operative wound or conjunctival dehiscence may be the cause for it. identify it and try to correct it. So how do we identify? Look for the conjunctiva in the postoperative period very carefully. As I mentioned, the fornix-based flap tend to leak in the postoperative period. Use a very good magnification. Still, it is not visible on this. If you keep increasing to high magnification, you can see there is a small gap here that is likely to cause a leak, especially when you press on the eyeball. So how will you know whether it is leaking or not? So you use what we call it as a Seidel test. It is a very simple test. Use a sterile fluorescent strip, wet it with a paracaine, any local topical anesthetic, and paint the bleb area sufficiently. And then you use the red free to look for the leak. Usually you see the leak under high magnification, and such a situation, in the immediate 1 or 2 days, nothing to worry about, but it persists and the bleb is not forming, then you have to consider treatment. What it can cause shallow antechamber if it is significant leak, ocular hypotony, choroidal effusion, late bleb failure due to the early leak. So these are some of the signs: low intraocular pressure, shallow antechamber, shallow bleb indicates a bleb leak. So most of the time, as I mentioned, observation in a day or two, usually it settles down. One can consider aqueous suppressants so that aqueous is not leaking through, that the healing will be faster. If it persists, bandage contact lens works very well for the fornix-based conjunctival flap leaks. Sometimes patching may be helpful. Reducing topical steroids is not ideal because you need good amount of steroids for a successful trabeclectomy. If the problem is significant enough, one may have to go for the suturing of the conjunctiva. Coming to the serous choroidals as a complication, most of the time the cause is wound leak or excess filtration. And when you have a choroidal, suppressed aqueous protection results in the flat bleb that causes the scarring. The trabeclectomy fails over a period of time. So correcting the serous choroidals is very important. So look for the cause, correct the cause, automatically the serous choroidals will subside. And you can have the problems much later also. And if you can correct these problems, you can still salvage these trabeclectomies. What are those conditions? These are the wound leaks. These are the kind of the blebs we used to get with the limbal-based flap. This was the incision site, which has scarred down and produces steel of ring. So it produces a very localized bleb, and the aqueous tends to accumulate in the bleb. At one point, it gives way. Wound leaks can be a localized single point leak or a diffuse leak. When you have a localized leak, you can have a conservative approach, but sometimes people have tried a bandage contact lens, aqueous suppressants, and one may have to do that with topical antibiotic drops to avoid possible infection. When we use the antimetabolites, most of the time it doesn't work out. So a single leak can be corrected with autologous blood injection, whereas a diffuse leak needs a surgical revision of the blood. I'll just touch upon the autologous blood injection. It was 1993, it was proposed by Weiss, where 1 ml of the venous blood was taken. 0.1 to 0.2 ml was injected before it coagulates using a 27 gauge needle into the bleb after entering the subconjunctival space 6 to 8 millimeters away from the bleb. Complications: the blood can enter the antechamber and produce the hyphema, or where blood failure can happen. Rarely it can produce even endophthalmitis if there is a possible source for the infection. So this is how a 26 gauge needle is entered in the subconjunctival space after taking the blood from the anterior cubital fossa of the patient. And once you enter the bleb site, slowly the blood is injected into the bleb area till the bleb occupies the bleb. So this is how you manage a small leak, and at the same time you can preserve the function of the trabeclectomy. So these are some of the points that I wanted to share with you that helps in enhancing the success of the trabeclectomy and minimize the complications. Thank you very much for your patient hearing.
Thank you very much, ma'am. That was indeed a treat for all those doing trabeculectomy. And it's relevant to mention here that the trabeculectomy which you had done at the life surgery session of the GSI 2007 at Kolkata, she's still doing very well, had come to see me during the COVID about a week back, and still without any medication, her pressures are around 14. So excellent, absolutely, lasting for 13 years, a trabeculectomy, which is like, I think, really wonderful. And thank you once again for accepting our invitation and being with us. There are questions for you, but we'll take it after the next lot of talks, ma'am.
Okay, thank you very much.
Thank you. So we move on to the next talk, Dr. Shirisha Senthil. If you're ready, you can share your screen.
Yes.
Good evening, everyone. Can you see the slides?
Yeah. Go ahead.
Right. Yeah, thank you, Chandrima and friends for the invitation. So the topic is my glaucoma patient has cataract, and what challenges do I have and what considerations do I have while I do a cataract surgery in these patients. So this is a very common situation that we encounter. In elderly patients, cataract and glaucoma do coexist, and when the surgery is indicated, there is a dilemma. What is the best approach that we deal with in these patients? What is the choice of cataract surgery in them? What happens to glaucoma control after cataract surgery? I think these are the two considerations that we definitely should have. So how do you choose a surgery? Do we do a combined surgery? Do we do only cataract? And if we do only cataract, what do we do preoperatively, intraoperatively, as well as postoperatively to take care of the intraocular pressure control in these patients? So to understand that, I think there are two basic concepts that we need to understand. Why does the intraocular pressure control after cataract surgery in patients with glaucoma, and how does that happen in different types of glaucomas? And I will be specifically looking at the POAG and PACG, and how is it different in different glaucoma subtypes? What happens to intraocular pressure control after cataract surgery, or to be precise, how does the intraocular pressure control in a patient with primary open angle glaucoma following a cataract surgery? So in POAG, we know that there is a microscopic blockade in the juxtacanalicular trabecular meshwork. What happens in these patients is there are morphological changes that happen in the trabecular meshwork beams as well as the intertrabecular spaces, and some changes that happen also in the endothelial cells because of multiple mechanisms that have been proposed. And that actually increases the trabecular outflow. In essence, this is what it is. And there are multiple studies that have actually proved this. But if you look at this, there is a very modest decrease in the intraocular pressure following cataract surgery in patients with POAG. It could range anywhere from 1.5 millimeters of mercury to up to a maximum of 4 millimeters mercury in various studies that have been published. And studies also have shown that higher the initial intraocular pressure, that means the higher the preoperative intraocular pressure, greater is the magnitude of intraocular pressure reduction following cataract surgery. In contrary to POAG, in angle closure glaucoma, we know that there is a significant decrease in intraocular pressure following cataract extraction. So I think I would like to concentrate a little bit on angle closure, because this is an area where I think we need to understand what happens to the intraocular pressure control and in whom do we do cataract surgery alone and where we should avoid doing cataract surgery alone. We know that lens plays a very significant role in intraocular pressure elevation in angle closure glaucoma patients. When you look at the multiple mechanisms that we have, relative pupillary block is the primary mechanism that all of us agree. And there are also other two mechanisms, that means opposed PI, occludability or anteriorly positioned iris root, as well as the ciliary processes cause a condition called as plateau iris syndrome. And also anterior positioning of the lens or increase in the lens thickness, that is the lens vault, both of which cause a significant contribution in angle closure. So what happens in these patients? There is a mechanical blockade of the pupil. So by removing the lens, you are trying to decrease the artificial lens is obviously much less thicker. So it increases the space in the anterior chamber. Not only does it do that, it also decreases the posterior crowding forces that the lens offers. So by both of these mechanisms, it causes a posterior fall of the iris diaphragm as well as helps to open up the angle. So now let us look at what cataract surgery does to intraocular pressure control in various types of angle closure glaucomas. We know that in angle closure glaucoma, the intraocular pressure control is far greater than POAG following a cataract extraction. We also know that when there were studies that were conducted in comparing phacoemulsification alone versus combined surgery in angle closure glaucoma patients, those with medically controlled angle closure glaucoma, the intraocular pressure control was definitely much better with combined surgery. However, the complication rates were also quite high with combined surgery. So, in fact, our study, which had just concluded and the paper is almost ready, we found that there was almost an equal amount of intraocular pressure control in both the surgeries, slightly higher with combined surgery, though over a period of time it almost equalized, but the visual acuity recovery as well as the complications were far less obviously in the cataract surgery alone group. What happens in medically uncontrolled angle closure glaucoma? I think this is a very, very important slide and please concentrate on this. So those with chronic angle closure glaucoma with uncontrolled intraocular pressure, when trabeculectomy was compared with phacoemulsification, TRAB had better outcomes but obviously had more complications. And also when a combined surgery was compared in these two groups, the patients with only phacoemulsification had higher intraocular pressure over a period of time as well. I will come to that a little later and explain you in a little detail. When primary phacoemulsification was compared to surgical iridectomy in patients with uncontrolled intraocular pressure following acute angle closure, phaco was far effective in controlling the intraocular pressure. Now, what is the role of clear lens extraction? Clear lens extraction, all of us would agree, definitely has no role. I wouldn't say no role. We wouldn't be comfortable in doing a clear lens extraction just because we want to control the intraocular pressure, because we know that there are a lot of other problems that we have to face with in these patients if we do a cataract extraction in a clear lens, which we can comfortably control the intraocular pressure with a PI, following which medical treatment should be able to help. So looking at what the EAGLE study told us, the effectiveness of early lens extraction in the treatment of primary angle closure glaucoma, they compared clear lens extraction versus standard care, that is the LPI, and anti-glaucoma medications in patients with PAC and PACG at 3 years. And these were the results. A forest plot showing the differences between the two subgroups. They looked at the quality of life scores in the two groups and also looked at the intraocular pressure control. The blue line here tells you the line of no difference, and the red line is the line of difference. And if you see that the forest plot and the red line actually is favoring the clear lens extraction. But what does this actually mean and what do we take home from this? I would not go into the details, but what I would like to draw your attention to is this. There are several drawbacks in this study. I don't want to go into the details, but I'm sure several of us who have read the article understand that surgery is an invasive procedure. The intraocular pressure difference that they had actually shown was about 1.18 millimeters of mercury on an average. Medications differed by about 0.33. Complication rates were quite high, with number of eyes having malignant glaucomas in the surgery group. And data could not be, it definitely cannot be extrapolated into our population because this was majorly done in Chinese eyes. And of course, the cost of medications and follow-up versus the surgical cost is something that we will not accept. So one has to weigh the risk and the benefit of clear lens extraction, and I would definitely say a no to clear lens extraction. So when do you choose cataract surgery alone and why? Definitely cataract surgery has advantage in that it is a predictable procedure, single surgery, less complications, early visual recovery. However, the problems are early intraocular pressure rise plus what happens to the IOP control over a period of time, and the patient has to continue anti-glaucoma medications. Complications we need to understand: despite doing a good cataract surgery, those with acute angle closures especially are very high risk of developing corneal decompensation because of the shallow anterior chamber that they have, as well as the endothelial cell loss that are associated with patients with acute angle closure. So this is something that we need to understand, especially when you have to consider doing a phacoemulsification in patients with clear lens. When do we decide to do a combined surgery? We have to understand the severity of glaucoma, the IOP control that is necessary post-operatively. Patient is on multiple anti-glaucoma medication. Is the patient allergic to medications? Is the patient not able to afford and non-compliant with medications? These factors will definitely play a role before we decide on a combined surgery. So just a guide that I would take you through is, if the main concern is cataract and the glaucoma is well controlled, consider doing a cataract surgery. If the intraocular pressure is a main concern, that means that the pressures are not very well controlled. The pressures are controlled well with multiple medications, and the patient has allergy to medications or is not able to afford medication or is non-compliant. These are some of the indications where you would definitely consider doing a combined surgery. I'm not saying combined surgery is bad, but if you ask me, is combined surgery something that you prefer in all patients? I don't think so. I would consider cataract and glaucoma as two different problems in the same individual. Cataract is the main issue. I will tackle that. And if intraocular pressure control is the main issue, but patient also has a cataract, I would do a combined procedure in these patients. So a few slides that you would take you through what happens to IOP control following cataract surgery in glaucomatous eyes. There's a very nice ophthalmic technology assessment article that is published, the effect of phacoemulsification on intraocular pressure control in POAG, PACG, and pseudoexfoliation eyes. Early intraocular pressure spike is definitely a concern in these patients, and that is undesirable. And when I say a spike of more than 30 millimeters of mercury after surgery, especially on day one that you see, this can happen in close to about 30 to 40% of the patients if we don't take care of the IOP in the per-operative period or in the immediate post-operative period. And what do we do for it? We can, study has shown that if you give them oral acetazolamide in the immediately after surgery, in those, of course, we have to worry about those who are not able to tolerate, but most often they tolerate, and this itself can decrease the IOP spikes to as less as 5% in the post-operative period. What happens to intraocular pressure reduction over a period of time and the number of anti-glaucoma medication that decreases? If you look at this, it is the least in POAG as expected, and it is the maximum in angle closure glaucoma, and the maximum is in acute angle closure glaucoma eyes. That means just by removing the cataract, amount of IOP reduction is far higher in angle closure and in acute angle closure glaucoma eyes. What happens to the long-term intraocular pressure control in these patients? So how would you look at it? Number of eyes requiring anti-glaucoma medication in the post-operative period, as well as number of eyes requiring glaucoma surgery. So if you ask me that, if you look at this table, the group of patients who require glaucoma surgery in the post-operative period, if you see, close to 20% of the eyes actually require a glaucoma surgery in the years to come in patients with uncontrolled primary angle closure glaucoma. I think I would like you to concentrate on this slide and take this home, this information home, because any angle closure glaucoma, irrespective of the intraocular pressure control, if you think just by removing cataract we will be doing good, I think it's not wrong. It's not right. If you see over a period of time, especially in the long term, over 1 year and 2 years, they will definitely have an elevation in IOP, needing a glaucoma surgery. So if you have an uncontrolled angle closure glaucoma, intraocular pressure in an angle closure glaucoma patient, it is preferable to do a combined surgery. Will glaucoma progress after cataract surgery? By looking at the visual field progression, again, if you see this over a period of time, it happens in most patients. In uncontrolled angle closure glaucoma, close to 40% of them have had a progression of glaucoma following cataract surgery, if it was the pressures were uncontrolled prior to cataract extraction. So to summarize, I would say cataract surgery definitely has a role to play in decreasing the intraocular pressure in patients with glaucoma, more in angle closure compared to pseudoexfoliation compared to POAG. Except in acute angle closure, in PACG eyes with uncontrolled IOP, consider combined surgery. But controlled IOP, you can do a cataract surgery. It's very, very good, not just for IOP control, but also for visual rehabilitation. And patient factors have to be considered before you choose a surgery. And of course, a close follow-up is necessary not just for IOP control, but also to look for field progression over a period of time following cataract surgery. Thank you for your attention.
Thank you, Dr. Shirisha. That was indeed a very informative talk and great guidelines for all those treating cataract and glaucoma. Thank you very much. We have questions, but we'll take it after this series of talks. So I'll move on to Dr. Prafullo Sharma. Dr. Prafullo, you can share your screen if you're ready.
My slides are visible?
Yes, clear. Go ahead.
So good evening, everyone. At the beginning, I would like to thank Dr. Sondima and everyone at Kolkata Academy for having me here. Actually, Dr. Shirisha, she has already covered some of the aspects of my talk, so there may be a little bit of overlapping. I will try to avoid that. So my talk is post-EAC PI, anterior chamber remains shallow, is lens extraction and option. So I start my presentation with briefly presenting a patient, relevant patient, which I have been following for last 13 years. This 53 years old gentleman, actually, he had a shallow anterior chamber with moderately raised intraocular pressure. He was diagnosed as primary angle closure at the time in 2008. He has a family history of glaucoma. His binary grading was 1 to 2 and conioscopically 1 to Shepard's grade 1 to 2. This was his visual field reports in 2008. We have been following up this patient till 2017. In between, his intraocular pressure raised, and we actually raised our treatment. Number of drugs we increased. In 2017, actually, he started slowly having enlarged cupping, especially in the left eye, and intraocular pressure went beyond control. So at that time, in 2017, actually his pressure was 34 and 48 in right and left eye respectively. And by that time, the EAGLE study report was out. So we had a discussion with him regarding clear lens extraction. But following laser PI, he had a laser PI in 2008 itself. Following laser PI, as his angle was relatively open, so we had some doubt and we decided to avoid that. Then we went on with medical treatment. And in 2017, slowly his left eye optic disc cup increased. This is his RNFL optic nerve picture, OCT picture. It shows damage to the left optic nerve, and the right optic nerve was normal. His pressure was 19 and 25 and 26. Angle was open in some quadrants and it closed in the superior quadrants. So we decided to go with a trabeculectomy in the left eye. And subsequently, that patient needed a trabeculectomy in the right eye also. One eye, in left eye, intraocular pressure remained under control, but in right eye, I am still struggling with 3 drops actually. Now the question is, could I have managed this case in a different or maybe in a better way? Now, in the next couple of minutes, actually, I'll try to answer this question. We know that the mean anterior chamber angle wide is in handy normalized is around 35 to 40 degrees. The population-based studies have established that deeper anterior chamber is associated with wider anterior angle wide. As anterior chamber depth decreases, the risk for angle closure also increases. Angles from 0 to 20 degrees are considered to be capable of closure. So these are occludable angles. We say a shallow anterior chamber is a common accompaniment of angle closure disease. The 2 main mechanisms responsible for development of the primary angle closure spectrum of diseases are pupillary block and plateau iris configuration. The standard care of primary angle closure and primary angle closure glaucoma is laser peripheral iridotomy followed by medical management. Laser peripheral iridotomy, it eliminates pupillary block. It allows the iris to flatten, opening the angle of the anterior chamber angle. All the angle parameters actually, it increases after a laser peripheral iridotomy. Now what happens if the chamber remains shallow in those cases, as it happened in my case? So after PI, if the chamber remains shallow, it rules out that pupil block as the cause or rather sole cause of shallow anterior chamber, and it is not the sole cause, and the patient should be reassessed for presence of other causes. There may be plateauitis, there may be lens-induced secondary angle closure, there may be malignant glaucoma, so on and so forth. So we have to try to find out the other causes, whether it is present or not. So in absence of any other cause, is a cataract lens removal an option in such cases? Yes. If there is cataract, definitely we have seen in our previous presentation also, there are many studies which say that by doing a good cataract surgery, all the angle parameters increases, intraocular pressure comes down, angle wide significantly increases. Now the question is, what happens if the lens is clear? The topic has been debated for many years. To understand the answer, we need to know about the various determinants of anterior chamber depth. More specifically, what is the role of the crystalline lens in anterior chamber depth and angle closure? A very important study was carried out in the Singapore signage eye study. This study was carried out to identify the determinants of anterior chamber depth and to ascertain their relative importance. Various determinants were actually studied, and they found that approximately 80% of the variability in anterior chamber depth is explained by these 8 parameters, and majority of the variability is explained by only 2 parameters, that is the lens vault and the posterior corneal arc length. Lens thickness, contrary to the popular belief, it was not associated significantly with anterior chamber depth. Now, as Dr. Sirisha has already mentioned about this important study, the EAGLE study. The EAGLE study, despite having many limitations, it has actually conclusively shown that clear lens extraction, it showed greater efficacy, and it is more cost effective than laser peripheral arythmy followed by that is this standard care. The clear lens extraction, it has better efficacy. So I think this is my last slide. So I can conclude that the crystalline lens plays a pivotal role in primary angle closure spectrum of diseases. The lens in these eyes may be thick and anteriorly positioned compared with normal eyes. So removing the lens, it creates more space in the eyes and it widens the angle, which is enough to achieve lower IOP control of interpressor. So with significant improvement in technology and skill, clear lens extraction, especially in those cases of angle closure with increased lens vault, it can be helpful in preventing development of glaucomatous neuropathy in future. So in selected cases, if the anterior chamber remains shallow despite a patent peripheral arythmy, instead of going for the next level of treatment, actually we can remove the clear lens extraction. That is what I believe and some evidences suggest. Thank you so much for your patient hearing.
Thank you, Dr. Profullo. That was indeed a wonderful talk, and that's a ongoing debate between glaucoma and cataract surgeons, and we have questions for that. We'll come back to that. So I move on to Dr. Ganesh. Dr. Ganesh, you can share your screen if you're ready.
Thank you. Am I audible?
Yes, you are.
Yeah. At the outset, I would like to thank Madam Dr. Chandrima Paul, Dr. Rajesh Chaudhary, Dr. Shumit, and my close friend, Dr. Surjit Chakrabarti. Dr. Prafulla still has to...
You have to share your screen.
Actually...
Yeah. Dr. Prafulla has to...
Yes.
He has to...
Stop the screen sharing.
Yeah. Okay, good.
Yes.
Yeah.
Yeah, fine.
Right. So I'm going to cover device-assisted trabeculectomy, and okay, that's good. So the indication of glaucoma surgery is any threat to vision you have to reduce. So if the other options are not available, for example, distance from healthcare, inappropriate conditions, adverse effects of the medications, or ineffective, or patients who are non-responders, compliance as an issue, adherence as an issue, then this becomes indications of glaucoma surgery. Now, ideal surgery is something which is easily performed by all surgeons, requiring simple instrumentation, minimal complications, replicable technique with short learning curve, economic with long-term success. Sounds like cataract surgery, but we're trying to achieve this in glaucoma surgery as well. So devices to assist in trabeculectomy include briefly, there must be many more, but we'll just stick to Olegen implant and the Express mini shunt. And I am stepping on Dr. Sunita Dubey's topic just a little bit on gel shunt. I'll tell you Zen gel shunt. I'll tell you later why. But most commonly and easily accessible to us are the Olegen implant. Express was available, but then now it's the product has been taken off the market. It's not very easily available, quite expensive also. But nevertheless, we will touch upon this as well. So Olegen was touted as an alternative to MMC, especially patients who have a contraindication or MMC cannot be used. And marketing was that it's an anti-scarring agent without chemical inhibition, and results in a prominent filtering bleb with successful surgical outcome, biocompatible, biodegradable, and comes in a ready-to-use pack, unlike mitomycin, which you have to sort of prepare and start using it. And there's always a human factor when you prepare mitomycin C. That's a risk factor. And how is it used? So the surgical techniques remains unchanged. The company recommends to apply a loose stitch over the scleral flap and place the Olegen over on top of the scleral flap, as you can see here. That's the Olegen here. And then you suture the conjunctiva over the scleral flap. But these are the factors which advantages of Olegen over mitomycin C. There's no clinically significant risk known. It's non-toxic origin, non-teratogenic, natural wound healing without mitomycin C, physiologic, and you get a good, nice vascular bleb. Comparable success rate as compared to MMC, biocompatible, biodegradable, quick deployment without preparation, and safe surgical time. So these are the touted advantages over mitomycin C. But we are all doing a lot of surgeries with mitomycin C. So certain situations, Olegen can be preferred. And it comes in two models which are very commonly used in India. One is the disc shape. It's 6 millimeter by 2 millimeter. And then if you want to use for multiple patients, you can get a larger piece and then cut it into two and then use it between the two patients. Applications of Olegen include a thin conjunctiva, failed trabeculectomy, pregnant woman, mitomycin C where it is contraindicated, for example, patient with rheumatoid arthritis, patients with thin sclera, damage in the conjunctiva, which you have a scar, a previous buttonhole or something, and you can also use it as a scleral patch to tube exposure. Other uses are also mentioned in the literature. So you heard Dr. Vijaya talk about releasable suture. So if you were to use if you were to use Olegen, you would understand that you cannot see the suture through your Hoskins lens or any lens because the Olegen will and you cannot do a suture lysis. So for this, it's very important that when we use Olegen, we use the releasable sutures also. And Vijaya Madam has nicely mentioned that numerous reference. What we usually use is the reverse of the Cohen and Osher's technique, which was described in 1988. And the advantage of using the releasable suture is that you have the advantage is that you need a forceps to manage it later. Time is saved. You don't have to go to the laser room to do a laser suture lysis. Visualization of the suture is not a must. And immediate post-op complications are very less, mainly because you apply them very, very tightly. The disadvantage is that the extended suture track may act as a wick. The exposed stump may cause a windshield wiper keratopathy, and early removal can lead to a shallowing of the chamber. Suture can always be something you have to plan ahead of time. So this is how you apply the suture, releasable suture. You have the crosses show the needle exit, the dots show the needle entrance, and then you start from the sclera, go into the scleral flap, come out of the scleral, go into the scleral flap again near the limbus and come out in the cornea. And you can pass the needle into the cornea so that the whole suture stays in the cornea and you can cut it flush. And you take the loop, which is loose here, and then tie a 4-throw slip knot over the loop, which is on the surface of the scleral flap. So this is a video showing that. So this is the first bite. We're going to a 3 releasable suture, mainly because once you place the Olegen, you never know which releasable suture is going to be pulled out first, number one. Number two, releasable sutures can get fibrosed. And if they sort of get fibrosed, then it's difficult to remove it. You may have to let it go. You may not even be able to do a argon laser suture lysis. So there goes one of your potential for releasing the sutures. So we have applied. This is the second, and once you take the scleral bite, you come over this suture on the surface, and then you tighten it. So you have 3 loops, and then once you have all your sutures in place, you have cut flush with the cornea, the suture which on surface, and this is the Olagen implant. What you do is soak it, and then you push it deep into the beneath the conjunctiva. And the important aspect is when you are taking scleral bite, you must not include the Olagen in your bite. It can get exposed, it can get infected. So it's very important that suture tract does not pass through the Olagen. Another very important thing is never use Olagen with mitomycin C. That is something which we don't practice. There is some literature available to the effect that say mild dose mitomycin can be used with Olagen, but I personally don't use it. Either I use mitomycin C or Olagen. And once you have taken the episcleral bite and tied the conjunctiva, these are the wing sutures on the right and the left. And you can see the Olagen really sitting nicely on the apex of the scleral flap. And once you have tied the sutures, you find that the conjunctiva is brought nicely over the limbus and covering the PI. So that's a nice apposition. Coming to the expressant, this is a small device, 3 millimeters long, 400 microns in diameter, made of implantable stainless steel. It's blunt, needle-like tip. Additional side holes prevent the iris plugging, and lumen is not actually a cylinder. So the indications for express shunt, very severe advanced glaucoma where you don't want sudden decompression. In one-eyed patients with advanced glaucoma, complications of mitomycin C on the other eye. Of course, many people do recommend that you use mitomycin C with the expression. This is the device which is going into the antechamber. It has something like a collar stud, small collar stud, and it just remains there. The flange at the outside doesn't allow it to go inside, and there's a small collar stud in the inside which doesn't allow it to come outside. So once you place there, you can apply the releasable sutures, and then you can close the scleral flap. So other situations include, like I said, rheumatoid arthritis, patients who are highly prone for snuff out syndrome. These are all the other indications for the express shunt. Xeljan shunt is another device. I'll tell you why we are talking about this in a trabeculectomy situation. It's a small, hydrated, minimally swelling, swells and softens and becomes flexible. And presently, this is a image courtesy of Dr. Andrew Briganza. You can see the Xeljan shunt there, and gonioscopy, you can see this here. Now, presently, the company recommends that you can implant it over the through the conjunctiva. So this is a video courtesy of Dr. Grover. And although you don't have to lift the flap, I know Dr. Sunita Dubey will be covering this more extensively, but this just to show you that you could go from outside to inside and also have a filtering device in the from the antechamber into the subconjunctival space. So although you don't have to, it's not part of a trabeculectomy process as such, but you could still think of this. Sometimes we always feel that in a situation, there was some device which would take the fluid out of the eye. You know, we were not able to do a trabeculectomy, we were not able to do a tube shunt. The only remains is what for us to do is a diode laser or something like that. But we always feel that if there was a small device which would take a fluid outside the eye, it would relieve all our anxiety managing the situation. So the device is there in the antechamber and filtering. This is combined with the cataract surgery, and you can see the device just there in the subconjunctival space. So with this, I would like to thank all the organizers for providing me this opportunity to speak to you on device-assisted trabeculectomy. Thank you.
Thank you very much, Dr. Ganesh. That was indeed a very interesting talk with really nice and interesting videos, absorbing videos. With that, we move on to Dr. Sathi Devi. Dr. Sathi, you can share your screen if you're ready.
Yeah. Is that visible?
Yes.
So thanks, Dr. Chandrima and the Kolkata Academy for giving me this opportunity. So I would be talking about the Ahmed glaucoma valve. The two commonly used valves in India are the Adi and the Ahmed, and I'll be talking about the Ahmed glaucoma valve. So the basic principle in most valves remain the same. Most tube surgeries remain the same. So there is one episcleral plate. There is an attached tube, and one end of the tube is placed inside the eye. The tube is covered with allograft or autograft material, which prevents tube erosion, and the bleb always forms posteriorly near the equator. Now, where would we like to do tube surgeries? In those eyes where the glaucoma is quite refractory, where conventional glaucoma surgery like TRAB has already failed, or it is highly likely to fail. So these are the situations where we would like to use a tube implant. And so this is a picture of a failed TRAB. You can see the angry looking conjunctiva and the scarred bleb. So this is a good situation where you can do a tube implant surgery. This is neovascular glaucoma. In this situation, one could look at doing tube surgery as a primary surgery. This is a patient who has had neovascular glaucoma in both eyes and tube implants in both eyes. In the image on to my left, the tube is placed in the sulcus. In the other image, you can see that the tube is placed in the anterior chamber but close to the iris. Pediatric glaucoma, where multiple other surgeries have failed, this child required a second tube implant surgery inferiorly for controlling the intraocular pressures. In buccal eyes, and in the image below, you can see that there is also a SICS section scar there. So the conjunctiva is scarred. So in this situation, a TRAB would be extremely difficult. If there is superior scarring, a tube can be placed inferiorly, as in this post-PKI. In PKIs, where in penetrating keratoplasty, where the anterior segment is disorganized, or in eyes with K-pro, in ocular cicatricial pemphigoid, where the conjunctiva is scarred. If there is a superior PAS where you know that the TRAB is likely to fail, eye syndrome, uveitic eyes, especially if it's in a pseudophakic eye, then the chance of scarring of the bleb with TRAB can be high. This patient is aphakic post-endophthalmitis. You can see the extensive membranes over the iris. Aniridia, where again management can be difficult. You can see the aniridia implant here. So now just to go over the surgical procedure for tube implant. Good exposure is very important. Adequate anesthesia is required. I prefer to give a peripulpar anesthesia. Corneal traction suture gives a good exposure. Usually the supratemporal quadrant is chosen. Phonic space conjunctival flap is taken almost 3 clock hours with 2 relaxing incisions given vertically. A good dissection is done posteriorly underneath the tenons. Take care not to cause a buttonhole in the conjunctiva or to rupture the tenons, and take care not to cause damage to the rectus muscles also. Light cautery is applied and adequate space to place the implant is created. Next, the implant is primed. Here a 27 gauge needle is used to prime. The BSS is seen flowing through. Hold the implant very carefully, making sure that you don't damage the valve. The part where the valve is there, the assistant or the surgeon should not touch the implant. So the implant is placed well posteriorly so that it stays snug in the pocket that is created. So that's the area. The area in red is the area that touching with forceps or pressing on this area should be avoided to avoid damage to the valve. Once the implant has been placed, the suture is passed through the eyelets, and this is then sutured to the sclera about 8 to 10 millimeters behind the limbus. The suture should be taken parallel to the limbus, and make sure that you do not perforate the sclera while taking these bites, especially in high myopic eyes. The knots are tied tight and they are cut flush. The knot is then buried inside. So both the sides, the sutures are taken. You can also do this as a single suture technique. I'm sorry. And so the tube is now cut to the desired length. So about 1 to 2 millimeters of the tube is what you expect to go into the anterior chamber. And a 23 gauge needle is bent in a Z shape to allow easy passage. I like to go about 3 to 4 millimeters behind the limbus and take a long tunnel. So this prevents the tube having the acute turn, which can then give rise to tube exposure. Pass it in the either in the sulcus or into the anterior chamber, but it has to go parallel to the iris. Some visco is put at the tip of the tube. Now the tube is passed through this track that has been created with the 23 gauge needle and carefully passed into the area where you plan to place the tube. So here the tube has gone behind the iris. There is some part of iris which is covering the tube. I make a small nick inferiorly to release that. One can make multiple attempts of entry if we're not satisfied with the initial entry. Once the tube has been placed, a suture is placed on either side of the tube, and this is tied on the sclera. This is just to hold the sclera against the tube against the sclera. So this is not meant to occlude the tube. This is just to hold it in place and prevent movement of the lateral movement of the tube. Now a partial thickness scleral patch graft is being placed. Again, I don't take bites within the patch graft. I take 2 parallel bites on either side of the patch graft, and this is then tied tight in a crisscross fashion over the implant. One can also use a corneal graft in its place, and that would also help in visualization of the tube. Once this is completed, the last step is to, that was the final suturing of the conjunctiva. You oppose the 2 corners and then suture the rest of the conjunctiva. Complications again are quite common. They are seen with this surgery, and here you can see the tube touching the cornea and causing early corneal haze in this area where the tube is touching. Here also there is tube cornea touch, and there is more extensive corneal decompensation. Tube exposure as seen here. This is plate exposure. You can see the edge of the plate has got exposed, and the area where the sutures have been taken is also exposed. Here more of the plate is exposed. Along with the exposure, here we are seeing infection. The plate is almost the entire plate has come out, and you can see that there is discharge, purulent discharge sitting on this plate. So a very high risk of endophthalmitis, because we need to remember that the tube is inside the eye. The tube can get blocked by vitreous, as in this eye you can see, and then you can have an increase in the intraocular pressure because it doesn't allow drainage of the aqueous. Tube can also be obstructed by the iris, and this as seen in this image here. Encapsulated bleps can also occur. So to conclude, glaucoma tube implants are a valuable option in the surgical armamentarium in the management of complex refractory glaucomas. Complications do occur, some of which can be quite serious, but meticulous surgical technique and patient selection can minimize the incidence of complications. Thank you.
Thank you, Dr. Swati. That was an excellent talk and great surgical videos. Thank you very much. With this, we move on to a talk which was actually scheduled to be done by Dr. George Puthuram, but unfortunately he had a sudden medical emergency at home, and so he's not able to join us today for the talk. So the talk, near about the talk, will be given by my good friend Dr. Shushmita, who very readily agreed to do it for us when I spoke to her last evening. And thank you, Shushmita, once again for bearing with us. You can share your screen and go ahead.
Hi, can you see my screen now?
Yeah, we can see your screen. I think at the you can take your cursor to the bottom and go on that. Yeah, that.
Okay,
Yeah.
yeah, that's fine. Right, so this was short notice. Thank you, Dr. Chandrama and Kolkata Academy at the outset. So when she said patchless graft, I remember there was a presentation in which I did mention George's patchless tube draft, which has just been published in the American Journal. So I thought I'd just combine it with the tips for safe tube placement, and we'll go along with that. So, right. So the glaucoma drainage devices in children is a very useful armamentarium for all of us who are doing glaucoma surgery in children. And many small kids have had their visions preserved because of that. And literature is now full of drainage devices, both the valved and the non-valved, where the vision has actually been preserved. Just one caveat of the difference in a drainage device when you put it in children versus adults is that children have eye growth and they have a tendency to rub, and they also are more prone to trauma. So that must be kept in mind. And I found one interesting article which had 52 children versus 130 adults. And the complications that were more in children were tube retraction or migration, and that was attributed to eye growth. But adults had more corneal decompensation, so that's something interesting to keep in mind. Now, the problems of tube placement in children, of course, would be that the limbus is stretched and the anatomy is distorted. And like we said, there is migration and retraction due to growth. And the optimum length of tube placement may be unpredictable. So this young girl actually with Axenfeld had one tube and was perfectly all right, except that the IOP wouldn't get controlled. And despite repeated limited diode photocoagulations, she landed up with another tube and she was one-eyed. The other eye had already been lost due to glaucoma in childhood. And when we put in the next tube, actually, whatever happened to it, it triggered a migration of the original tube. So we just went ab interno and had to snip the two. So this happens. This is not very uncommon. The other thing to remember is a quadrant placement. So sometimes, especially now, this child had open globe injury, retinal detachment, and silicone oil. When you have silicone oil, it's always advisable to have a tube in the inferior quadrant. Inferonasal is easy to place, and that's because the silicone oil would move up and it can pass through the tube and cause fibrosis. It doesn't block it, but there's a higher chance of failure because of that. So here we see that the internal opening is widened a little bit. And one trick is to cut the tube from below up. That's easier than taking our hands all around and trying to cut it with a large bevel. So then it really goes in quite easily. This was an Adi which was being placed in a silicone oil. So the other challenge is if you're dealing with optical penetrating keratoplasty, sometimes a persistent corneal scar requires an OPK, but then they're gifted right back to you because the post-BK glaucoma is also common. So the main thing to remember is to keep the tube below the host cornea and not go on to the graft, because the graft is something which you really want to preserve. So this is how it's actually done. So this was this child with a persistent scar after a CTT, and she was fine. But at 3 years, when she had an OPK, she came back with glaucoma and required an ADI. So you see this, the host is opaque, but this tube is going in just underneath that, and it stays away from the graft. Sometimes we don't have a choice. We need to put it in the sulcus. If it's pseudophakic, there's no problem. So this is a post-cataract surgery glaucoma came to us. So if it's pseudophakia, you just have to have a little longer tube which peeps at you at just inside the pupil, and then that's all right. So in a minute you'll see it under retroillumination. This would be where we would keep the tube in case we put it in the sulcus. But if you have an Axenfeld or any other cause of closed angles, that might be a problem. Sometimes one tends to be heroic and then one realizes one shouldn't. we thought that with this much of iris atrophy, we could somehow manage to keep the tube beyond the lens equator. And though we tried our very best, but then on the next post-op day, this was actually sitting on the peripheral part of the lens. So now fingers are crossed, and we hope it's not going to cause an opacity, but you need to be very, very careful in conditions like this. So when we had these phakic eyes with hardly any anterior chamber, with no space, you wouldn't like to take out a clear lens. You would like to preserve it as much as possible. So the one thing that we've tried to do, this is another axon-filled girl, and we actually called it a peephole. So just use the vitrector and make a little bit of a hole there and insert the tube such that it's beyond the equator of the lens, but one can see it. So we did that for this child because there was no space at all in the anterior chamber to put in the tube. And this actually sat very well, and she's doing all right. You can see this is the periphery of the lens, and this is where the tube is. So we called it a peephole, and that's interesting in some. Another small tip is, in case the pars plana is chosen, you must do a skirt vitrectomy even in a vitrectomized eye. And we learned that the hard way. We put this tube in the sulcus in a vitrectomized eye, and next morning we were horrified to see all these vitreous strands going in. So remember, even in a vitrectomized eye, a skirt vitrectomy might not be done. So we learned that, and we had to go in. You can see these sutures are absolutely fresh, but we couldn't jolly well have these strands of vitreous going into the tube. So we had to go in next day and then cut up all the vitreous. And once it was all clear, you can see the tube is completely clear of vitreous. So we learned our lesson. And in a vitrectomized eye, even if it is vitrectomized, we first do a very thorough anterior vitrectomy under the iris before implanting the tube. So this really was George's paper. This is an Orolab drainage implant they've done with a long tunnel, very similar to what Dr. Sati had just shown us. And they haven't used a patch. The beauty of this paper was that it was a randomized control trial of patients with a patch and without a patch. And the interesting thing is that you've actually had lesser erosions in patients without a patch, and they discuss it out that probably it's because the ocular surface is smoother and there's lesser irregularity because of the graft. So that's something to keep in mind, that this 4 millimeter tunnel could be quite useful in even avoiding erosions, though intuitively we would think that without a patch there would be more erosions. This is something that Dr. James Brandt has shown. So this micro crescent blade is available, no financial disclosures, alas, but it's available from Sharp Point. But this is very useful. This was also in a post-PK lady. I was very, very apprehensive of post-PK because any disturbance of ocular surface results in graft failure. So this goes in very well. Dr. James Brandt calls it a windshield wiper sort of movement, and it's very smooth. So this tunnel is formed and it's more predictable. It's just that at the end, he says it's okay to make a small flap, a tiny flap like a tram, just to insert it in. And you'll see next morning, this is absolutely smooth, this ocular surface. There's nothing, no irregularity and nothing, and touch wood, she's done all right. So this is something to keep in mind, that you can avoid a patch if possible. So the take-home points, of course, the surgical nuggets. The tube entry should be as far possible to the limbus as possible in children. Cover the tube with either a patch graft or make a scleral tunnel. And the tube should always be inserted parallel to the iris and secure the plate very, very well to prevent movement. But tell the parents that the children do not press on the globe and rub their eyes. And these two sisters with microcerophakia, very, very bad glaucomas, between them have 2 tubes in each eye. So they have 4 tubes between them, but then at least they're going to school and they seem to be doing all right now. So thank you to the entire team. You can't do any childhood glaucoma alone, to the babies and all the residents and senior residents along the way. Thank you.
Thank you, Dr. Shushmita, for doing such great justice to that talk. Thank you very much indeed. And you can go ahead with your own talk now.
Yeah, I'll do that. Right. Thank you, Dr. Chandrima, for the opportunity to do George's as well as mine. I think the slides aren't shared. Are the slides being shared? No.
No, no.
No, I'll have to just stop this one then. Yeah, is this visible now?
Yes, yes.
Yeah, okay.
Yes.
Right. So step-by-step surgery, really, because pediatric glaucoma is a surgical disease. It's like an ocean. Once you start doing and working with these children, it's similar on the surface, but it has countless myriad hues within. And these are all different diseases requiring different things. So really, there is no one surgery for everything. And surgery has to be tailored to the situation that we have in mind. You can't have a one-size-fits-all solution. In a nutshell, for primary glaucomas, if the angle is visible, an angle surgery works. So this is infantile glaucoma, and a year down the line, you can see how the corneas have cleared. A goniotomy, if the angle is visible, is a good. Ab interno and the conjunctiva is not violated at all, it's a good surgery to do. But then if the cornea is hazy and you can't see it, for instance in this acute hydrops, then a combined trab with trab for hazy corneas where you can't see the angle is really the workhorse procedure. Dr. Mandal has published extensively on the long-term effects of combined trab with trab, and they do very well in children. Once your surgery fails, you have a choice of a glaucoma drainage device or a limited diode laser photocoagulation. Second trabs really work too well, but what we have also tried to do is now treat the rest of the angle once a combined trab with trab fails, and in some babies that works. So a limited DLCP, just to reiterate that in children it's important to transilluminate. We transilluminate all of them. This is just a pen torch, and you'll be surprised at how variable the ciliary body is in these children. And sometimes you'll realize that you're doing laser photocoagulation on the sclera without really knowing that the ciliary body has gone far back. So transillumination in DLCP is one thing that has worked. And for secondary glaucomas, if the conjunctiva is healthy, usually we do a trabeculectomy with mitomycin, and that works. And if the conjunctiva is scarred, post-PPV OPK, we do a primary glaucoma drainage implant without even trying to do a trabeculectomy sometimes. So coming to the goniotomies, if it's a reasonably clear cornea, the advantage is it's direct. You slice the non-functional trabecular meshwork by directly visualizing the angle, and provides a conduit for the aqueous to bypass the meshwork and go to the Schlemms and collector channels. The only tips are the microscope needs to be tilted. Most microscopes have that mechanism now, and the patient's eye needs to be tilted. So you see the light from this patient's eye goes straight into the surgeon's, and the surgeon sits directly opposite the angle to be operated. So this is a short one. This is Axenfeld. You can see these iris processes and very, very prominent. So I'll just take it a little further to show. So this is the treated angle. You can see the iris has fallen back, and this is the untreated angle. So you just need to go on with that just above where the iris is inserted, and this cleft in the angle opens up, and this is really where it's going to go out, the aqueous is going to go out of the eye. The other thing we've learned to do over time is to treat as much of the angle as possible. And what I mean by that is, in a minute you'll see, now I've treated as much as I could in one, and now I've turned this lens to go a little further, and you need a smart resident or senior resident who's going to really take this globe and rotate it for you. So once the globe is rotated, so my knife is here and I'm waiting for the globe to be rotated, and you'll soon see that once the globe rotates, you will also, so say that. So now that it rotates, you also have access to all this angle which is not there. So you don't need to stop at the traditional 120 to 150 degrees. You can go further. And usually now we manage about 180 degrees at one go by just a simple rotation of the eye and do as much as possible. Of course, nowadays with the eye track, the 360-degree trabeculotomy is becoming very, very popular, and that seems to work very, very well. But we do as much of the goniotomy as is possible in one sitting. So it's been an encouraging journey so far. This is a typical infantile onset PCG. You can see the hazy cornea with the central harbs. And 3 years later, she's going to lower KG now, or she's going to get admission, and just one goniotomy has worked. Sometimes one is not enough. So this is a baby who we've done the other eye as well. So that's the first thing. We don't go in and do a trab. We try to treat as much of the angle. Why you can see this finger between is because there's a nose here. So it gets a little tricky to do the temporal angle because you're sitting where the nose is, but it's possible. And this is also 2 or 3 years later, and then both corneas have cleared with 2 goniotomies. So with 2 goniotomies, near 90 to 95% success in a year is what we've seen so far. But these are early days yet, and we hope it'll continue to be that. So a combined trab with trab really is a workhorse situation, as Dr. RK also showed us. So this is what we usually do, and this is an extremely stretched limbus with a visible diameter of 16 millimeters, but when you open up the eye, the actual diameter is even more than that. So if you have a smooth bed, you just make the cut across the white meets blue, where you know the Schlemms will be looking at you, and you just go sideways and you see the bead of aqueous coming. And then we like to make these radial cuts as well. So it's easier for the trabeculotome to enter. And once the trabeculotome enters, you follow it up with the trabeculectomy. And that's about it. So there it goes in. That's one end going in. And then similarly on the other side. And then you complete the trabeculectomy. So this is the other. This is a Harm's trabeculotome. So this goes into the anterior chamber, doing the same thing like the goniotomy, except that you're also cutting the trabeculectomy along with it. So you do the trab. I like to use a vanas in children because it's a little more controlled, because maybe it's more elastic, but you can use a punch as much as you can use a vanas. And then the iridectomy, and that's it. So usually, and if you notice, the limbus is far back here. So the actual surgical limbus is much further than where you see the anatomical limbus there. And they clear quite well. And if this is sparing the pupil, I think the child will have good vision. It's extremely gratifying in acute hydrops. Dr. Mandal will be showing his series as well, but believe me, no mothers are more happy than an acute hydrops. And this is the really stretched Harb's striae leading to the acute hydrops, which you can see on retroillumination on the microscope. Neonatal onset PCD, very, very gratifying if you do them. She was operated at 2 days of age. So do it as soon as possible. And she is also now almost 3.5 or 4. Again, going to school with 1 CTT. Very, very gratifying when you do them. So the question of, like I said, if the trab fails, but the cornea is reasonable. So we thought, let's try to treat the rest of the angle with the goniotomy before opening up the conjunctiva again. So it is possible at times. And as you see that you go across the anterior chamber and then put in your lens. And so it does clear. So this is after the hazy cornea, first CTT, and then a goniotomy, and then it clears. So you have so much of the angle left. If you can, try to treat the angle before going into a combined. Of course, glaucoma drainage device is a boon. Dr. Sati has shown, we've already talked about it, so I won't spend too much of time. We've published our results of ADI in pediatric glaucoma in the BJO, but it's followed up by articles from the PGI and LV Prasad and now from Arvind. So the ADI really is part of ophthalmic literature now and is very useful. Just one little thing, remember when you're dealing with small children, babies have lives. So this is a 2-day-old baby with the right eye Peters, and to our horror, when we did a UBM, the lens was actually sequestered within this huge Descemet's defect of Peters. So though we did the CTT in both eyes, the left eye cleared well, it was PCG in the other eye, but this became an unsightly blind eye because we couldn't do anything about this lens. So remember, there's no point in making the child carry on with this, and we encourage the parents to go in for an evisceration and a prosthesis, but now the baby is going to school, has grown up. So it's important to remember that as well. So childhood glaucoma is a challenge. Early diagnosis and treatment hold the key. And as Dr. RK said, constant evolution and ideas make it a better treated condition than before. And it's not a dismal prognosis as was first thought to be. Thank you. I acknowledge the team.
Thank you very much. As usual, wonderful talk. And thank you very much. We move on to Dr. Sunita Dubey. Dr. Sunita?
Yeah.
You can go ahead.
So I am sharing my screen.
Yes, please.
Can you see my screen?
Yes, we can.
Yeah, so at the outset, I would like to thank Dr. Chandrima and the Kolkata Academy for this wonderful opportunity. So I'll be talking on MIGS. And as we know, the surgical management of glaucoma is undergoing a period of revolution, with MIGS becoming an increasingly important and exciting approach in the management of glaucoma. MIGS were basically designed to bridge the gap between the medical or laser therapies and more invasive filtering surgeries in mild to moderate glaucomas. Both trabeculectomy and tubes are well-established procedures that have been successfully employed for several decades, and we have been doing them. However, they may be associated with some complications which can be sight-threatening, as we have seen. So MIGS being mostly ab interno, conjunctival sparing, and largely bleb independent procedures may offer reasonably high safety profile. So MIGS can be used earlier in the course of the disease, especially if the patient is undergoing cataract surgery, and especially if the patient is allergic to the eye drops, or there's a toxicity, or there are issues related to the cost and non-compliance with the medication. So it has a wide range of indications. As we know, trabecular meshwork and inner wall of Schlemm's canal are the site of maximum resistance in primary open-angle glaucoma. And if you look at the anatomy, the Schlemm's canal drains to 25 to 35 collector channels, which transmit aqueous to the intrascleral and then to the episcleral venous plexus. But if you see, it's not a continuous thing, and the density or the number of episcleral vessels, they are much more in the nasal and inferior quadrant as compared to the other quadrant. And therefore, any surgery performed in the nasal quadrant becomes more successful. MIGS can be classified based on their physiological mechanisms and anatomical sites of action. The class of MIGS to reduce the outflow resistance, facilitating aqueous drainage into the Schlemm's canal by bypassing the trabecular meshwork via some stent like iStent or iStent inject, or by dilatation of the Schlemm's canal like devices like Hydrus, or by removal of trabecular meshwork. So excision of trabecular meshwork by either the GAT or trabectome or Kahook dual blade. And in fact, I've started doing some of these procedures now on a regular basis. Then there is other type of procedure which improves the uveal scleral outflow via the suprachoroidal space, but somehow they are not being done because of the complications associated with them. And the third one is to improve the subconjunctival drainage by either the Zen stent or preserve flow. So Dr. Ganesh has already talked about the Zen stent, and because of the limited time, I won't be able to cover all these. And we are already doing the ciliary body mix, endocyclophotocoagulation, and TSC-PC and micropulse, which improves the flow through the ciliary body. So I'll be concentrating more on the procedure, which I've been doing for last 1.5 years now. So I'll be talking about trabectome, which is a stand-alone device and utilizes a controlled plasma-mediated ablation system, and it is a unit with constant infusion and aspiration through the device, which maintains the chamber and provide good visibility to facilitate ablation by removal of tissue debris and blood reflux. And it has a foot plate at the tip, which helps guide the electrosurgical tip and protects the adjacent tissues from being damaged. Now they have Trabex and Trabex Plus. So basically these are not standalone unit, but these are just these laser cut serrated blades. However, the Trabex Plus can be connected to phaco with the for irrigation and aspiration thus the blood reflux management can be done with Trebex Plus. And this is serrated edges with guided control tape, which prevents the structural damage to the surrounding tissue around the arc of the eye. So this is the phaco compatibility of Trebex Plus. It's very important to have proper position and setup when you're doing this angle surgeries, and the best view is achieved when the angle of the microscope and the angle of the eye is around 70 degrees. So you have to turn the head of the patient away from you around 35 degrees and the microscope towards you around the same degrees. And it's very, very important to be aware, to be knowing the intraoperative gonioscopy properly, because you have to identify the structures, the trabecular meshwork and the ciliary body and the Schlemm's canal, so that you can target the correct tissue. The surgery as such is not very difficult, and you have to make an incision 1.8 millimeter the temporal cornea. And as soon as you decompress the eye, you can see this blood congestion inside the Schlemm's canal, better seen here. And this is the way you can identify the trabecular meshwork. And then you just introduce the probe, this trabectome, with irrigation on into the eye, put the gonioscope lens, and then start ablating from the center, first towards one side. And you should not encounter any resistance here. If you're at the right direction or right plane, then it will be smooth. And if you encounter any resistance, then you have to change the position. So similar as in goniotomy, you will see this white line as you proceed, and it is because of the ablation of trabecular meshwork and the inner wall of de-roofing of the inner wall of Schlemm's canal. And this white line, what you see, is the outer wall of Schlemm's canal. And as you complete the procedure, you can see this blood reflux, which you can easily clean with your irrigation aspiration at the end of the procedure and maintain a watertight closure. So trabectome has the largest record, and it has completed almost 13-14 years, and this is the meta-analysis of 4,600 patients, and with a good survival curve, about 66% in trabectome alone and 85% when it is combined with trabectome with phaco at 6 months, and a lot of phaco with trabectome. And the trabectome is done first, and it's very important again to re-emphasize that the identification of the angle is very important. And once you make the incision, you just enter with the trabectome. And again, even with the dilated pupil, you can, if the angle is open, you can see the angle very well. And you can just ablate the trabecular meshwork on either side and open up the angle. And you keep rotating the gonioscope to have the wider application of the trabectome, and then you can go ahead with your routine phacoemulsification. So you are just adding 10 minutes more to your routine phaco, and just at the end of the procedure, you can just reform the anterior chamber. So the procedure is quite effective, especially in patients with POAG pseudoexfoliation. This was one patient who underwent phacotrabeculectomy in one eye, and this is the angle. And the left eye had mild glaucoma, so I decided to do a phacotrabectome. The eye remains quite, it remains quiet the next post-operative day. There are minimum, inflammation, and the pressure also in most of them is able to is controlled. So I'm just sharing this 57 patients data in last 1.5 years, and I've included most forms of glaucoma, mostly POAG, but other forms as well, the congenital JOAG and some secondary glaucomas, PACG after PI and the opening up of angle, and even advanced glaucoma also have done initially. And the trabectome was combined with phaco in 42% and alone in 58%. And there was a good reduction of intraocular pressure, 48% on day 1 and 36% at 6 months to 1 year, and reduction of medication as well. But as you can see, most of these patients have to use some medication. Patient is not off completely medication after this kind of surgery, as you do see in case of trabeculectomy and all. But the safety profile is very good. And the phacotrabectome versus trabectome, again, I had better results with the trabectome and with the decrease in the number of medications. I would just like to share this case of congenital glaucoma who presented at the age of 5 months, and she underwent bilateral trap plus trap within 1 week in both eyes, and the one eye was doing pretty well, and the cornea cleared, and the good bleb was there. The corneal diameter stabilized, and however, one eye, the other eye, the corneal diameter was increasing. There was edema, and the glow was dull. So I tried to do needling in this patient, and after 1 year, I decided to do trabectome, and you can see the angle. There is high iris insertion and dysgenesis of the angle. In this patient, it's very important to keep the child under deep anesthesia so as to avoid the forward movement of the iris. And you can see here the opening of the angle, and you can see the Schlemm's canal, outer wall of the Schlemm's canal here, this white line. And this patient is doing very well. So this is the patient now. She is 2 years old. So to conclude, the greatest advantages of MIGS is the preservation of conjunctiva for more invasive glaucoma surgeries like trab and tube in future if required, and reducing the bleb-related complications. And for milder diseases, they have definitely broadened the therapeutic options and can be combined with cataract surgery with good outcome, and with reasonably good decrease in intraocular pressure and medication burden in vast majority of cases. Although the patient is not completely off medication, that one has to remember. And however, we do need more evidence to decide the best treatment option for each individual patient of ours. Thank you very much for your kind attention.
Thank you, Dr. Sunita. You've really left us with food for thought regarding the next decade of surgical glaucoma practice. So with that, we move on to Dr. Anil Mandal.
Hello.
Yes.
Yes.
Great. Yes, you can go ahead.
Yes. Yeah. The screen is here.
It's below the share screen at the bottom. Yes, that's fine.
All right. Is the slide visible, Chandrima?
Yes.
All right. Thank you. Thank you, Chandrima and Surajit, for inviting me for the Kolkata Academy of Ophthalmology meeting. The topic for my presentation is acute corneal hydrops in infantile glaucoma. Let me start the story of this child, a 3-month-old child. The parents brought the child to the emergency in the evening when I was about to leave the institute. This is a story of 2013. The child was having beautiful eye, prominent eye, and the parents were very happy. But one sudden morning, the child started developing sudden corneal clouding. As you can see,
a clouding in the left eye. The parents rushed to the emergency of the institute. I happened to examine the child, took the child to the physician, got the physician's clearance done, and admitted the child. To my judgment, it was acute hydrops related to infantile glaucoma. Apparently, the corneal diameter was large. When we did the examination under anesthesia, corneal diameter in the right eye was 12 millimeter and in left eye it was 13.5 millimeter. Now, even though the diagnosis is apparent, each situation of this kind, the child must be evaluated thoroughly, ultrasound B scan should be done, and total evaluation should be done to establish the diagnosis. Otherwise, similar presentation can be misleading, where a posterior segment pathology, particularly retinoblastoma, can present like this. Anyway, the child was evaluated, left side surgery was performed, primary combined trabeculotomy and trabeculectomy, and you can see, just compare and contrast the appearance at presentation and this photograph. The left eye photograph was taken 10 days after the surgery. And here is the situation, 6 months postoperative appearance, the cornea is totally clear. Now, at the 6th month EUA, we photographed the child's cornea under fundus retroillumination and saw that this is the typical HABSTI we see in developmental glaucoma. Now, pathogenesis of acute hydrops is related to megalocornea associated with high intraocular pressure, and when pressure goes beyond certain limit where the Descemet's membrane cannot withstand, it gives away and allows aqueous to enter into the corneal stroma, giving rise to acute corneal hydrops. Now, the story of this child was reported in the New England Journal of Medicine, sudden corneal clouding in an infant. Now, let me tell the series of patients we saw in last 23 years, from 1990 to 2012. Our idea was to evaluate the surgical and the visual outcome of infantile glaucoma who presented to us with acute corneal hydrops. This is a 23-year story, retrospective study. All the patients managed by me by primary combined trabeculotomy, trabeculectomy were included in this study. 38 eyes of 31 patients who presented with acute corneal hydrops were included. 7 patients were having bilateral affliction. The mean age at presentation was 6 months, ranging from 2 to 11 months, and the median follow-up was about 3 years. All the patients, 38 eyes, had sudden corneal edema, and in the postoperative period when the cornea cleared, we saw HABSTI in all patients. The intraocular pressure reduced to 12 plus minus 3.8 millimeter of mercury from the preoperative value of 25.6 plus or minus 5.1 millimeter of mercury, percentage reduction being 53%. Most of the patients, 84% of the patients were having topical anti-glaucoma medication when they presented to us, and in the postoperative period, in the long run, 2 eyes, that is 5% of the eyes, required 1 postoperative medication for control of intraocular pressure in the form of topical acetazolamide. When we looked into the visual acuity of the patients, best corrected Snellen's visual acuity data was available for 27 eyes, of which 44% of the eyes were having normal vision, 22% eyes having low vision, and in 33% of the eyes, visual acuity was significantly reduced because of HABSTI and its effect on the optic nerve. When you looked into the refractive error data, 3/4 of the patient was having astigmatism. Simple myopia was there in 1/4 of patient, and of the patients who were having astigmatism, again 75% were having compound myopic astigmatism. And in some children, the cylindrical power is significant, and sometimes, astigmatism was antimetropia. One axis was plus hypermetropic, and other axis was severely myopic. Now, when we evaluated the entire series, 31 patients, 38 eyes, combined trabeculotomy was done. The structural outcome was 100%. Only one patient required one topical anti-glaucoma medication. The visual outcome was reasonable, and the rupture of the Descemet's membrane leading to a high astigmatism, and that astigmatism must be corrected. And in the long run, in the follow-up of the patient, correction should be given to make sure the child has the best chance of good vision in the affected eye. And amblyopia therapy must be done to make sure that it is treated properly. Now, the patient presents with hazy cornea. And to start with, if you look into the history, most of the parents will tell that the child was having beautiful eye. The big, beautiful, prominent eye is a sign of botheration. Actually, not a sign of beauty actually. And here is the situation. Simultaneous bilateral presentation was there. Left eye was more severely affected than the right eye. Simultaneous bilateral primary combined trabeculotomy and trabeculectomy was performed. And here is 6 months postoperative appearance. Right eye cleared completely, and the left eye in the Habs eye region, little haze is there. It took slightly more time to clear. You can see in the right eye, the eye which is afflicted in the milder form of the disease, you can see the Habs eye circumlinear, slightly away from the limbus, and it is not coming into the pupillary axis. In the other eye, that is the left eye, which was more severely affected, the patient was having Habs eye, which is crossing the pupillary axis. Naturally, this is the patient which will require good refractive correction, and in spite of good refraction, the visual acuity may not be very good. So this is the bleb appearance, 1 year bleb appearance of the right eye, 1 year bleb appearance of the left eye, and here is the composite picture. Simultaneous bilateral combined trabeculotomy, trabeculectomy, based on our experience, we feel is safe and effective. And proper correction of refractive error should be given. Long-term follow-up is necessary to make sure the child will have chance for good vision in both eyes in the long run. The series was presented or published in 2016 in a journal, PLOS ONE. Our experience of 23 years, 38 eyes of 31 patients was treated. That's it. Thank you.
Thank you. Thank you very much, Dr. Mandal. With that, we'll move on to the question answer part of it. And there are actually a lot of questions, but we'll have to just pick and choose. I think the first question that we'll pick out here is how cooperative is the patient while doing a trab on topical anesthesia? So I'll start from the keynote speakers, and then I'll go on to the panelists. Sir, Dr. Ramakrishnan, if you're here, you have to unmute yourself.
Yes, Sandrima. Doing trabeculectomy and topical, usually I don't, I want to, I have done only very few cases where the patient themselves, they ask for topical. Otherwise, I always prefer either readable bar or even now mostly subtin. It's not advisable, especially for the beginners, better not to try and topical because very much painful You have to cut the conjunctiva, then you have to do iodectomy. And movement, another thing is movement. And IOP, because of movement, the patient can squeeze the eye, and this will produce a shallow chamber and hard eye. It's very, very difficult to do under topical anesthesia. Unless we are very much comfortable and very experienced, and you should be able to tackle any intraoperative complications.
Thank you, sir.
Hard to try.
Thank you, sir. Ma'am, Dr. Vijaya, ma'am, are you here? She's muted. Okay, we'll move on to the panelists then, and then we'll take opinion from anybody else. So, the panelists.
Can I answer that, ma'am?
Yes, please. Sure. Yes, please, Dr. Devan.
So actually, excellent webinars. So congratulations for that, ma'am. And also excellent talks by the keynote and the others. All my glaucoma surgeries now are under topical, all trabs and all shunts. Just that in very select cases, we do subtenons. And I think that has increased my safety and overall success of the trabs very much. You can take opinion of the others.
Dr. Amit?
Yeah, no, I don't advocate topical because I personally feel if the patient becomes uncooperative and starts squeezing his eyes, and if the pressure increases and the eye becomes shallow, it becomes very difficult, and when you're doing a plain trap, also damage can be there. So I always prefer to have a peribulbar anesthesia when I'm doing a trap surgery.
Okay. Dr. Manish Pandey?
If I'm ready for complications, I'd prefer to have certain amount of block in my patients, especially for trabeculectomies. I always prefer some kind of block for my patients.
Okay. Can we have Dr. Sailaja and Dr. Mariam? Your opinions, please. Topical, you have to unmute, Sailaja. Unmute. Unmute.
I do not do topical surgeries for trabeculectomies. I do it under a peripheral anesthesia.
Okay. Dr. Mariam? Dr. Mariam?
Yes,
she is presently the president of the Ahmedabad Ophthalmological Society. Yeah, Dr. Mariam, are you here? Yes, please.
Hello.
Yes, please.
My actually internet gone. Hello. Yeah,
I can hear you. Hear you, ma'am.
Yeah. I am not doing topical. I am doing with the block only, peribulbar block.
Okay. Dr. Lippi?
Yeah, I think this question is now, it stands not so relevant, madam, because it's a universal consensus that most of the glaucomatologists, they even do trab under anesthesia only, under peribulbar anesthesia only, not topical. So it's not the way to go.
So could you quickly give your opinion, Dr. Shushmita, Dr. Shirisha, Dr. Sati?
Yeah, if I can just take that question. It's not like a fancy thing to do a trab under topical anesthesia, but actually it is a need for certain patients. So if you ask me, I do under topical, but it is not purely topical. Obviously, you start with topical, but we always give a small amount of subtenons, and that works quite well. So it all started off many years ago out of a need for advanced normotensive glaucoma patient who's progressing disease, and any amount of block is not something that the eye can take. So there were situations where certain patients were actually taken for surgery under general anesthesia because we don't want to give a block. In situations like that, where it is not comfortable to give a block or it's not safe to give a block, it started, and after that we realized that it was not a difficult thing, it was not all in your mind. So it's not like a patient actually squeezes during surgery. So you choose the patients, you have to counsel the patients very well and make sure that they do it. In fact, it's quite comfortable to do it under topical with a subtenons. I always give a subtenon. I give a preservative-free Loxicard or Ropivacaine because even a little bit of it goes into the eye. Anyway, for topical cataract surgery, we do that.
Yes.
So stretching of the pupil, even if you want to do a combined surgery, stretching of the pupil along with doing your trabeculectomy, they're quite comfortable. Iridectomy also, they don't even wince. They're quite okay. And you don't need a superior rectus, you don't need corneal traction. But you have to speak to the patient and counsel the patient very well. So use a torch and ask them, I'm going to speak like this and ask you to look down. This is how you will look down. Otherwise, they'll keep moving their chin down, things like that. So counseling is very important. Once they do it, actually you won't find any difference between a topical and a peribulbar. There are some conditions where if it is complex and if your lids are very tight and you find it very difficult to open the lid and the patient finds it very difficult to look in a certain direction, then those are obviously not the cases. In that situation, we give a very minimal peribulbar and block the lids. So that lid tightening is something, so it's a modified kind of, it's not a topical, but maybe 1 cc of peribulbar and then the lid block.
Yeah, prevent squeezing. Yeah.
Where do you give your subtenance?
Yeah.
In the trap, where do you give a subtenance? Is it through the same congenital flap area, or you make another opening inferiorly?
No. So what I do is topical, and then wherever I want to open the conjunctiva. Some people do it, let's say, you do it limbal based or phonics based on which type of incision you have chosen for this patient. I make a tiny nick in the conjunctiva and I use a cannula to inject it. I don't want to use a needle to inject it because in case if I don't include that in my incision of the conjunctiva, it may end up like a small buttonhole kind of a thing. So I always make a tiny nick with Vanus, and then you use this, so it actually, like in your needling, post needling we give a subpunch, right? So and then we spread it out. Once you spread, or a pre-needling also, many people use mitomycin and things like that. So you can spread it out, and that actually gives a very beautiful elevation of the conjunctiva, helps you to dissect the conjunctiva well. They have no problem with cautery. So it is quite comfortable to do it.
Shushmita and Swati, Dr. Swati, you want to add something to that?
Yeah, I agree with whatever Dr. So I like to combine some amount of subtenance anesthesia. I don't like doing plain topical. We need to understand that iridectomy can become a little painful. Putting your superior rectus suture may not be possible if you're trying to use a topical. Sometimes even with the subtenance, the superior rectus can be a problem. So high myopic eyes and certain situations like what Dr. Sirisha said, I might do a topical along with the subtenance.
Okay.
But pure topical, no. I think the patient does get a little uncomfortable with iridectomy. When you're doing cautery, they do have some amount of pain.
Yes. Dr. Shushmita, would you like to add anything to that?
I don't do topicals and subtenance. I'm very comfortable with my peribulbar. And of course, in the myopes and everything, you're a little more careful and you inject a little less, but I don't do topicals.
So the consensus is that we go by
Madam, can I add something? Yeah, this is Ganesh here.
Yes, please.
Yeah, so advantage of having subtenance is many of our patients are on prostaglandin and you have the fat pad approach. So once you give subtenance, it lifts up the globe and then you have much better exposure. So it's what type of glaucoma you're tackling. If this patient's been on chronic therapy for many years and he's got his, the periorbitopathy because of prostaglandins. So topical exposure and all those things become very difficult. As Dr. Sirisha mentioned, some amount of subtenance does help to lift up the globe, better exposure, and then proceed on with the surgery.
Can I just add a small thing that actually using this spectrum, which has a slightly longer arm to go into the inferior fornix, does making your eye move downwards. The exposure of the eye comes around without having to take the superior rectus or the corneal stay suture. Now, I do most of my trabeculectomies with peribulbar anesthesia. Having said that, I shifted away from the regular speculum in most of the eyes.
Yeah, that's known as the ONG speculum, ONG speculum.
Yes.
It comes for the right eye as well as the left eye. So you have to buy a pair. You have to buy a pair.
Yeah, exactly. And also, as Dr. Shirisha mentioned, in cases where you do not want to give a block because the optic nerve is already too compromised or in a high myope or something, those are the only situations where you might want to attempt a topical with giving a subtenance, but we really have to counsel the patient and you have to pay detailed attention to things like how much pressure you are, putting onto the eye with the speculum and other things, because it's not just the pain threshold that you're checking or how cooperative the patient is, it's also how well you'll be handling the tissue and all to make the surgery comfortable, because you want to be meticulous during your procedure.
Yeah. So on that note, we move on to the next question.
The next question is coming. Everyone in this group is a surgeon, and everyone has faced a blade leak once or twice or many times in the life. If there is labels like that, we normally give one antibiotic to prevent for further damage or endophthalmitis, etc. So, which should be the ideal antibiotic to start with? First, I want to ask you, sir, with the most experienced.
So your question was not clear, sir. Can you repeat it?
Yeah. Everyone is a glaucoma surgeon. Everyone has faced a labeling in their lifetime. And so for labeling, we start with an antibiotic before going for next procedure for the labeling. Okay, which should be the ideal antibiotic to start with?
Good question.
Yes, sir.
I don't, but usually we prefer to use this ofloxacin or ciprofloxacin. Usually ofloxacin, sometimes moxifloxacin we used to use. Yeah.
Moxifloxacin. Yeah. Ganesh, Ganesh.
Yeah, we prefer for fourth generation of
Anyone want to change it? Anyone, any other preference for any antibiotic we start with? Or everyone is, yeah?
Augmentin we can start. Broad spectrum antibiotic.
Ma'am, we'll get a topical. That question was, what is a topical?
Topical.
Yeah.
Topical antibiotic.
I would just like to add on that first we need to find the cause that why it is leaking and fix that cause as fast as possible. So a leaking bleb is always dangerous, whatever antibiotic.
So will you give antibiotic or not? In topical drops?
Antibiotic is needed, of course. Still we fix it.
And which one is the drop? Which drop? Fourth generation.
Ophthalmologists go with it in India.
Any controversy for this? Then fourth generation should be the idea. Yes. So we're going to shift to the next question. When we giving it two releasable suture, most of the surgeons, many surgeons have big triangular flap. One at the apex and two on the sideways. And for the two sideways, one may be a releasable suture. If we give two releasable suture, which one should you release first? Is there any preference for release the apical one first or side later?
So we'll start with RK, sir.
Okay, again RK, sir. Yes, sir. Dr. Vijay is also there.
I am using releasable for quite a long time, but I am not a fan of two releasable. I always put only one at the apex.
At the apex.
So fix it switch on the side. It's only question of surgeon's preference. I prefer always single.
Yeah, I think my intention of doing apex is that you will have a posterior flow. But I see a lot of people taking one permanent, one at the base. Two base releasables, the apex being the permanent. So what I do suggest them is whenever they are releasing that suture, and if it is superior nasal bleb, try to release which is closer to the 12 o'clock, so that the bleb will not go down into the palpebral aperture. So try to avoid that. So that is one thing that I keep telling the students. Other than that, nothing specific.
Yeah, that's a very good process.
Can I add something?
Yes, sure.
Yeah, so I think my approach is different. I do a rectangular with two releasables in the dead center. And then it doesn't matter which one to release. In fact, sometimes with mitomycin we always use. So at times you can release one and you may not have to release the other. So we cut it flush and bury it. But yes.
Is there a preference left side first or right side first?
So with that.
Yeah.
No. Both are quite close together in the center with a rectangular.
For rectangular, it's completely different. Yeah.
I would like to answer this, Sumita. I make a triangular flap. Usually I use one releasable, but if I'm using two releasable and one apical intermittent suture, I'm a right-handed surgeon. So when I make an L-shaped ostium with the punch, so usually the ostium is more closer towards the left scleral edge, that's left triangular edge. So if I have to release the releasable suture, I release the left suture first. Because once I release the left suture and give a bit of massage, because the opening is more closer to the scleral edge, that opens up very easily. So this is the way I go ahead with.
Right, very good. Ganesh, you want to add something?
No, I think the controversy is because I showed that video of 3 releasable, but of course that was a very specific situation where you use Ologen. You use Ologen. You really don't know by the time it's 6 weeks or 4 weeks, and you are attempting to release the suture doesn't come off. It will just cut, and you're left with no other way of managing that situation. But yes, if the Vijay
Network is poor.
I think the connection.
I think the connection is poor.
Yeah, Surajit, you can answer the question.
On that
it's a
note,
correction of the bleb.
okay, right.
Ganesh, Surajit can ask the next question.
Yeah, on that note, one question has come up from the audience. What is the cost of Ologen? A very known question. And how can you cut the cost of Ologen? Because in our country, it is very important. So
MRP printed on Ologen is about 12,500 rupees, 13,000 rupees. But bulk purchases, you get a discount, and depends on how you use the Ologen. That's even for the disc one, that is 6 mm by 2, it's the same price as the meter by 10 mm by 2. So if you start sharing between the patient, you can reduce the cost. But of course, as I said, with the very specific indications, we use it now. We don't use it as much as we were using it before, because now we have the RD with us, which is working very well in our hands, and we got to know how to use it. So many of the patients who used to undergo repeat trabeculectomy would undergo repeat trabeculectomy with Ologen. But off late now we are starting that, so that the cost of Ologen, I mean the usage of Ologen and all is sort of reduced. So it's only for traumatic glaucomas with a lot of severe injury we use Ologen, where we can do it. That's one, because we don't want to induce hypotony because of mitomycin C. They are young patients, collapsible sclera. You can induce a retinal detachment very quickly in them. And of course, high myopes, if you have to avoid using mitomycin C. So these are just 2 or 3 indications where we use Ologen. Not all patients as much as we were using before.
So Rojit, I think the maximum use of collagen, to my knowledge, in India is still in Kolkata. So I'm sure that question was from Kolkata, because
no, the question was not from Kolkata.
It's not from Kolkata.
Anyway, so I was just trying to say it's a fact that maximum use is still in Kolkata, and besides selective indications that Ganesh has rightly highlighted, I think in Delhi area, very few of us, we hardly use in routine traps. Yes, selective indications like myopes and juveniles and others, cephalomas and others, thin sclera, yes, those are indications, but otherwise we seldom use. I can say for other colleagues in Delhi also, we seldom use.
But is it advisable to cut the Ologen and use it? Surajit, Ganesh, your experience is it advisable to cut into pieces and use it? Because you get smaller pieces. Intact Ologen will be much better.
I mean, the disc we use singly. Disc is for one patient. Bigger sizes if you want to. But
that means if you have a 10 by 10 by 2, you can cut it into 2 pieces. You still get a 10 by 5 inches. 5 mm.
Ma'am, you were saying something.
So that is big enough.
Yes, the same thing. I think if you have a larger one, you can collect patients and cut it into 2 and use it. If it is a disc, it is meant for one patient. The smaller one, 5 is meant for one patient.
Okay.
Thank you.
So in the interest of time, we'll move on. There are a lot of questions. We'll take them as the cases go on. So we move on to the first case presentation, that is Dr. Parul Ichapurani. Could you share your screen, please, and start?
Good evening, everyone. It was a very wonderful evening with wonderful presentations and even a better discussion. So I'll go ahead with the case presentation. It's about a case of decompressive retinopathy happening after a trabeculectomy. So I had a patient who was 55 years old. She was hypertensive on irregular medication. She presented with an acute attack of angle closure in one eye. She was taking treatment for glaucoma, but there was no laser iridotomy that was done. She had a history of suboptimal medical compliance. The visual acuity was 636, not using glasses in the right eye. pressures in late 20s on acetazolamide and 3 anti-glaucoma medications. In the other eye too, the vision was 660. Pressure in late teens on the same medications. The cupping was advanced in both eyes, right eye being more than the left eye. So when she came to us, we did laser iridotomy first thing in both the eyes. And after iridotomy, we had to knock off the acetazolamide as she had gastric intolerance. But on the 3 anti-glaucoma meds which she was using, her pressures continued to be in late 20s. Her compliance continued to be poor. We suggested surgery, but initially she was reluctant. And later on, she agreed for a trabeculectomy in the right eye. We undertook the patient for TRAB with MMC under guarded prognosis as she had split fixation in the eye. So on the first post-op day, her vision dropped from 636 to hand motions, and despite an apical suture and a releasable suture, the pressures were 4. The anterior chamber was formed both centrally and peripherally, but there was a reaction along with some blood clots. The bleb was diffuse, but it was vascular. There was no leak, and we did an ultrasound and we found vitreous hemorrhage. So why the vitreous hemorrhage in a patient? And when I was doing the trabeculectomy, I had done a gradual decompression because I'd done a paracentesis while doing it. So I thought of a decompressive retinopathy. The patient was stable, the intraocular pressure, the blood pressure was stable throughout the procedure. She was taking her antihypertensive medications regularly. So seeing this, I started her on systemic steroids and increased the frequency of topical steroids along with atropine. Advised her not to rub or lift heavy weights and advised head end elevation. By the 8th day post-operatively, the vitreous hemorrhage had started clearing. The pressures had built up to 12. The bleb extent was good, although the vascularity was quite prominent. By day 12, the pressure rose to 22. I was doing a good massage even during the follow-up days in between, and then I started on timolol once a day. By this time of day 12, the retinal vasculature had started to appear, and the media clarity improved, and the vision also started improving. 3 weeks, and the pressures were 18 on single med. Since the vessels had now started looking angry, there was an element of subconjunctival fibrosis. So I started on oral indomethacin to take care of the cytokine storm, keeping in mind the hypertensive phase. A month and a half down the line, everything settled. The vision had improved to 618, the best corrected vision. The pressures were now 15 on once a day topical meds. And even the anterior segment OCT showed aqueous pockets diffuse in the posterior part of the bleb as well. 3 months, all looks good. The blebs are very diffuse, non-vascular. The pressures are controlled at 12. Now here, the dilemma which I had was that usually patients have multi-level retinal hemorrhages rather than having a vitreous hemorrhage. So why our patient had vitreous hemorrhage? We know that decompressive retinopathy has been associated with several procedures like even with a simple paracentesis, laser iridotomy, AGV, express shunts, and canaloplasty. So there are 2 theories which people suggest. The first being that the sudden drop in pressure, it results in change in the globe contour, which shears the fragile retinal capillaries. And there's expansion of the lamina cribrosa, which compresses the central retinal vein and also results in diffuse retinal hemorrhages. We did not see too many retinal hemorrhages in our case. We had diffuse, sort of dispersed vitreous hemorrhage. And since central retinal vein in a case of decompressive optic retinopathy is impacted only for a short time, the gain in visual acuity following decompression is much better than CRVO. The second theory suggests that there is a decrease in intraocular pressure level, which lowers the retinal arterial resistance, and because of faulty autoregulation of the retinal vasculature, it may cause rapid increase in retinal capillary blood flow. So our patient was hypertensive with compromised, possibly compromised vascular autoregulation. She had high preoperative pressures with a fluctuating profile, angle closure with a possible choroidal compromise, and the intraocular pressure reduction during TRAB, although it was gradual, it might have damaged fragile retinal capillaries leading to hemorrhage. But multi-level hemorrhages, as I said, should have been seen but were not there. So in a way, this also pointed out to the fact that angle closure is common in Indian patients, and many individuals, they report late with chronic PSEG or acute on chronic conditions, and they also have coexistent comorbidities like hypertension or diabetes, where there is dysregulation of the blood flow, and there this inadvertent complication can arise, and we need to keep this in mind. So old hypertensive individuals may not tolerate the hemodynamic changes in retinal and choroidal vasculature that are happening when we do a surgery. So in cases with advanced glaucoma, in addition to the risk of wipeout, we must apprise the patient of this possible complication as well. And a balance of steroids and non-steroidal anti-inflammatories with good bleb monitoring of each feature would probably help to fine-tune the therapy which we administer to the patient. So thank you for patient listening, and your comments are welcome for the case.
Thank you, Dr. Parul. Dr. Manju, would you please discuss the case? Dr. Manju, are you here? She was here. Dr. Manju, she's not here. In that case, then we have one of the panelists to discuss the case, or anybody else who wants to give an input into it.
Just to ask in this particular patient, I mean, it's interesting that you only had vitreous hemorrhage, because normally you'll end up getting, as you mentioned, multi-level retinal hemorrhages in this scenario. Was there any other predisposing factor in this patient?
Nothing. Just the fact that she was hypertensive. Probably she was not very compliant even with her anti-hypertensive medications. But at our center, we do PAC for all the patients. So that bit pre-surgery was sort of taken care of. So there was nothing which I could, even the surgery was entirely uneventful. There was no bleed during the surgery. It was entirely smooth. I was not expecting anything the very next day.
Was the pre-op pressure okay, or was the pre-op pressure really high?
Ma'am, I had given pre-op mannitol in the morning, and the morning pressures at the day of the surgery were 11.
That's pretty good.
Anybody wants to make any input into this case? Otherwise, we move on to the next case. Dr. Lippi, yeah.
Yeah, I would just like to add on. I could not go through all of your slides, Dr. Parul. I'm sorry for that. So this decompression retinopathy, actually, I have gotten some cases after TRAP, though it is very rare, but I got it in Arvind. So I think if there are IOP spikes before on and secondary glaucomas like uveitic glaucoma and even NVG, if in some cases we are planning TRAP, even juvenile glaucomas. So in that, there is more of this decompression retinopathy. That's what I have noted. So more of preoperative IOP spikes that there is more chance of.
That could have definitely accounted for in this patient, as she was very poorly compliant with the medication. But the only thing was that the hemorrhages were not there, and it was a vitreous hemorrhage. So that's something that I could not account for, and that made it interesting for me. So anyway, thank you for your input.
Thank you.
So we move on to Dr. Swati.
Yes,
Dr. Swati, yeah.
Yes, ma'am, 1 minute, ma'am. I'm sorry, ma'am. I had kept it open, but it's.
Is there an issue? Then we'll move on with the next case. We'll come back to you.
Yes, ma'am.
Okay, so Dr. Subhash Prasad, then we'll move on to you. Yeah.
Am I there?
Yes, yes, perfect.
Thank you, ma'am, for giving me this opportunity, and thanks to everyone of the Kolkata Academic. I'm going to present a case who presented to me 18 years poorly compliant male from poor socioeconomic status came with the complaint of decrease in vision for last 1 month, and he gave history of injury with a cricket ball 2 months back. And there was no records available to him, but he said that there was some blood in the eye which improved in a week, and then he regained the vision, and he was getting topical steroid, homatropine and timolol maleate. And when I examined the patient, I could see there was significant cataract, posterior subcapsular as well as cortical cataract. Vision was just finger count 1 feet. Intraocular pressure was 6 millimeter of mercury, and there was mild Descemet's fold. Posterior segment was very hazily visible, and the retina, it appeared that retina was on with indirect ophthalmoscope, but there was disc hyperemia with blurred margin. Other eye was perfectly normal. The B scan was done, and here you can see there is disc elevations and there is increased retinochoroidal thickness in this patient. This was seen by one of my colleagues working in my hospital, and he stopped the timolol maleate, and assuming that it is probably a ciliary shock or some kind of inflammation, it increased the topical steroid to 10 times and added some systemic steroid also along with atropine. And patient came back in 2 weeks time, but the intraocular pressure was even lower than the previous one. Rest status was same. So this time gonioscopy was done, and there was peripheral pass in the inferior lip, and I could see there was definitely a cleft there in the 5 to 8 o'clock position with the gonioscope. This is small video clip just to show. And doing gonioscopy in this situation is really very difficult because of the Descemet's fold and applying any pressure. All the area were clearly seen without any problem, but in the area of 5 to 8 o'clock position, there was a cleft which was just opening on, giving little bit of pressure on the eye. The pupil was already dilated, so we could not do it on a constricted or small pupil eye. You can see here a cleft there, which is nearly 4 o'clock hours on gonioscope. So we all know that gonioscope does not give true extent of the cleft. So one has to do some imaging technique to evaluate and to assess the extent, and even for follow-up also. So I thought I would do UVM, but the only UVM working in Patna was out of order at that time. So I thought I would do anterior segment OCT, and with the regular anterior segment OCT, it was not revealing too much. But when I asked the patient to go for SWEPS or OCT, you can see here there is communication. Here there is a cleft and a collection of the fluid in the suprachoroidal space. Here in the other meridian, and in the 6 o'clock position where I could be even with the gonioscope, you can see here there is communication. Another areas, you can see there is nice amount of suprachoroidal fluid. And since it was diagnosed that it is a case of cleft, so we thought to go in a stepwise manner. So the treatment basically depends on to induce the inflammation so that it closes itself, or one has to resort to direct closure by doing cyclopexis. So I stopped the steroid first, added cycloplegic. This atropine already he was getting. I thought I would do photocoagulation if it does not improve, and if it doesn't improve, then I heard and I read that CTR sometimes can put some compression over the ciliary body and can cause closure of the cleft. So I thought I would go for that, for cryo, or at the last, if patient doesn't improve, then I'll go for the cyclopexy. So the patient was stopped all the steroid, and it was asked to come after 2 weeks, but reported after 4 weeks, and there was no improvement, but the cataract has increased in fact. So I did the photocoagulation of the cleft with the lower frequency anti-YAG laser. And after 2 weeks, there was no improvement, but 4 weeks later, after the laser, there was some decrease in the Descemet's folds with intraocular pressure rising to 8 millimeter mercury. Since cataract had also increased, so I advised the patient to go for phaco emulsification with the CTR, and he was given the option that if it doesn't improve, then we'll go for the another procedure. So phaco with IOL with CTR 11 millimeter in sulcus was done. Post-operatively, patient was given minimum amount of steroid to induce some inflammation,
And 3 days later, patient visual acuity has improved to 612 with intraocular pressure of 9 millimeter. There was mild disc edema, mild macular fold. And 2 weeks later, patient had further improvement in the vision and IOP improved to 16 millimeter. You can see that this photograph, there's still some hyperemia with some choroidal, some macular folds here. Post-operatively, anterior segment OCT was repeated, and here this is the pre-op picture, and you can see here it has almost disappeared. And another view here, you can see the fluid, and it has disappeared here. So we all know that this cyclodialysis cleft is actually the separation of ciliary muscle from the sclerus spur, and gonioscopy is the key evaluation technique to assess or to diagnose the cleft. And one has to do the anterior segment OCT UBM. And in my case, I think that anterior segment OCT was better in delineating all the areas, and it was non-touch technique, and it could be repeated very easily. There are various strategies for management. There are so many, but I thought that after reading some article on using the CTR, I thought to go ahead with this technique of you doing the echo and putting the ciliary in the putting the CTR in the ciliary sulcus. So my case, I was able to diagnose the extent of cyclodialysis cleft. On gonioscopy, it was very much less, but in the SSOT, OCC, it was actually too much in extent. So just gonioscopy cannot delineate the true extent of the cyclodialysis cleft. And I am not sure whether my photocoagulation had worked or inflammation induced by cataract had actually worked, or was it CTR which actually compressed the ciliary body against the sclera. Later on, the inflammation led it to closure of the cyclodialysis cleft. So this is open to everyone for giving their suggestions and opinion, their experiences. Thank you so much.
Thank you, Dr. Subhash. Dr. Rita, would you please discuss it? Dr. Rita is here. Dr. Rita, yes, she's here. You have to unmute. Dr. Rita. In the meantime, we'll take any.
Can I say something?
Yes, please.
Yeah. So this is like typical. If you want to reduce the pressure, you should come to glaucoma people. If you want to increase, you can give to retina people, cataract people. The pressure will increase. But what Dr. Subhash has done is absolutely. My line of thought was the same. You need internal tamponade and also external. So if the internal works first, I think that's the best way to go. I think Dr. Shikha Gupta from AIMS has published a lot of work on that. All her papers, they are a little complicated surgeries, but worth going through.
Yeah.
Hello.
I think Dr. Rita is here.
Yeah. Can you see my screen?
No, we can't see you. You have to.
No, can you see my
start
screen?
Your video. No, you have to start video. Your video is off.
I'm sorry.
We can hear you. Okay. Yeah, there you are. Yeah.
And yeah, can you see my screen now?
Yes.
Okay. So I think this was a very well presented case. The basic thing that you got to actually know is that because it's not a very commonly occurring thing, suspension is very important, especially post-trauma, because this may present even years after trauma. Normally, the patient complains of a history of diminished vision in the affected eye, usually unilateral, and there is getting the history of ocular trauma, which could be either a trauma or it could also be an intraocular surgery before the patient has come to you. Because even doing simple procedures post phacotrabeculectomy, doing just a trabeculectomy, doing a retinal surgery, anything can be a potential for causing a cyclodialysis cleft in the future. So how do you diagnose this? You just need to do a good comprehensive ophthalmic examination, which was done right from the beginning. Gonioscopy, however, is the gold standard. And having done the gonioscopy, it is also important to look for other ocular pathologies and do a detailed retinal examination, because you've got to see whether there is a cataract, whether there is a choroidal, whether there are retinal detachments, whether there is an angle recession, because the treatment can then be coupled together. Having noted that there is a cleft on gonioscopy, you can actually confirm with imaging, which was done quite correctly by Dr. Prasad. He did not have access to the UBM, but he did have an access to a step source OCT, which is not a very common thing to have. But even a simple AS OCT can give you a pretty good resolution, and you can see the details of the cleft pretty easily. The advantage of using the OCT, like he told us, is that it's a non-invasive procedure. Hence, it's an easier procedure to do. To do the UBM with a soft eye is not the easiest solution. Now, looking at the treatment, sometimes a cyclodialysis cleft is known to resolve spontaneously, and the treatment is normally sequential depending upon the clock hours that are affected with the cleft. If it is less than 4 hours, you do something, and if it is greater than 4 hours, you do something else. Normally, you start with medical treatment if it is less than 4 hours, and correctly, as was started by Dr. Subhash, he did use a cycloplegic, and since the patient was already on topical steroids and systemic steroids, he had to stop off the steroids. But normally, post the cycloplegics and the rapidly declining topical steroids, it could take up to 6 weeks. After 6 weeks, if you still see no response, then you can move on to lasers, and there are many lasers that are used. You can use an argon laser. He had used an Nd:YAG laser, but it is preferred to use a transscleral diode photocoagulation because it does not cause any damage to the sclera. And the lasers have to be applied both to the ciliary body as well as the scleral spur to get adequate inflammation. And repeating lasers is pretty common. However, if all of this fails, then you have to resort to surgery, and you know that there are plenty of surgical options available to us. If the cleft is more than 4 clock hours, then I think nothing else works but surgery. But if it is less than 4 clock hours, then you can do the above, and then you can go on for surgery. There is no standard surgical procedure that has been explained. Yes? You can't see my presentation? I have done that. I've done it.
Oh, did she have a presentation? I thought it was just...
Okay, doesn't matter. If I'll just explain to you.
Just carry on. Yeah.
You don't really need to see my presentation. So if your cleft is less than 4 hours, then you can try everything else. But if it is more than 4 hours, you've got to go for surgery. And there are many surgical options that are available. You could do a cyclopexy, which could be a direct cyclopexy or an indirect cyclopexy. In large clefts, however, even if you want to do a cyclopexy, it might not be the best thing to do because there's a lot of sclera that you might have to dissect, and that is not really the correct thing to do. So you can go ahead and do a vitrectomy with a gas tamponade. That is found to be pretty useful. Now, since this patient already had a cataract, it was a very right thing for Dr. Subhash to do that he did the cataract, removed the cataract, put in an IOL in the sulcus, and he also used a CTR, which also was put in the sulcus, and that has been shown to be successful. The things to remember when you are doing this is that you must calculate the power of the IOL correctly, because when you calculate the power of the IOL, there is a hyperopia in these patients due to an AC shallowing, and also you're going to do an anterior placement of the IOL because now you're not going to put the IOL in the back, but you're putting the IOL in the sulcus. So you have to take these two things into consideration when you're calculating the power of the IOL to be placed. Also, the size of the CTR that you're going to place needs to be calculated well because you want the CTR to really stretch the sulcus so that it will cause the ciliary body to come in close contact with the scleral spur. And for that to happen, your CTR cannot be placed in the bag. It has to be placed in the sulcus. So the size to be calculated is that you have to take 1 millimeter posterior to the surgical limbus. So it fits excellently into the sulcus and you get a good closure. Sometimes in small clefts, even buckling has been tried. But if you have other associated pathologies like retinal detachments, etc., then of course you will have to go ahead and do a vitrectomy with a gas tamponade. So I think all that Dr. Subhash did was like really nice. He used the right method. Only the patient had come to him late, so he didn't have to wait for those 6 weeks for his atropine or the cycloplegic to act and for his steroids to act. Now there is a controversy about using steroids. There are some people who think that you shouldn't use steroids because that they are anti-inflammatory, but there are some who think that if you use the steroids, it helps in a way because you get a little rise in intraocular pressure, and that will probably help us in increasing the pressure and causing the eyeball to stretch out a bit, and therefore helping in resolution of the cleft. That is what my comments for this case were.
Thank you very much. In the interest of time, we'll move on to the next case straight away. Dr. Swati?
Yes, ma'am.
Are you ready?
Yes, ma'am.
Okay.
And you see my screen now?
Yes, yes.
So, first of all, I would like to thank Kolkata Academy of Ophthalmology and Chandrima ma'am, Surjit sir and Dr. Rajesh for giving me this opportunity. Today, I will be presenting a case of radius momini syndrome. So, our patient is a 32-year-old female who presented to us with painless progressive blurring of vision in the left eye since 3 months. She had no history of trauma, no significant past or personal history, no significant history of any topical drug abuse. So on examination, her right eye was absolutely normal, 6/6 vision, but the left eye had vision of 5/60, and there was gorged episcleral vessels with a grade 3 RAPD and a 0.9 CDR with a IOP of 42 millimeters of mercury by GAT, and the angles were open in both the eyes. This is the slit-lamp photograph of the left eye showing engorged episcleral vessels, and the fundus photograph showing a CD ratio of 0.5 in the right eye and 0.9 in the left eye. So we thought, what is the cause of unilateral engorged episcleral venous pressure, episcleral venous vessels, and elevated IOP? So we asked the patient to undergo an MRI of the brain and orbit along with cerebral angiography and orbital Doppler, which came out to be normal. So in the figure, you are seeing a digital subtraction angiography study of the patient, which is normal. Thyroid function test was also normal for the patient. So we came to the diagnosis of idiopathic elevated episcleral venous pressure with secondary open angle glaucoma with immature cataract, which we call it as radius momini syndrome. So we started the treatment, timolol maleate 2 times a day, torzolamide 3 times a day, travoprost once in the night, along with systemic acetazolamide 250 milligram tablets twice a day. At 2 weeks review, IOP dropped down from 42 to 36 in spite of 3 medications and 1 systemic medication. So we plan to take the patient for a carbon dioxide laser assisted sclerectomy surgery or class with classification for lens implantation. Intraoperatively, hypotonia was noted post sclerectomy by CO2 laser, so we decided to put a scleral patch graft in the same setting to avoid an overfiltering bleb. At 1 month post-op, the patient was having pressures of between 16 and 19 millimeters of mercury without any additional anti-glaucoma medication. These are the photographs which are showing. First, A is showing the red is the laser marks, laser indication that the COT laser is being focused on this part of the sclera. But in the second picture, as you can see, there is a brownish protrusion with some liquid. That is the laser has gone too deep. It should normally stop when it comes in contact with aqueous, but sometimes it goes beyond that, and so. To avoid overfiltering bleb post-operatively, we placed a scleral patch graft, as you can see in figure C, and then we close the conjunctiva, and the AC was well formed at the end of the surgery. So, idiopathic elevated episcleral venous pressure or radius momini syndrome was first described by Minas and Podors, and it's a diagnosis of exclusion. So, what we need to exclude is cavernous sinus thrombosis, dural arteriovenous shunt, superior vena cava syndrome, and most important caroticocavernous fistula, Sturge-Weber syndrome. So all these are, after ruling out all these things, we should come to a diagnosis. So we should rule out intraorbital and intracranial pathologies. Most cases are reported are over 20 years of age, and majority of them being women. Our case was also 32 years old women. And diagnostic evaluation should include a complete ophthalmic checkup as well as radiological imaging, MRI, DSA to exclude a cerebrovascular disorder. Now, we could have gone ahead with the trabeculectomy, or no, we don't know. So we thought such high pressures trabeculectomy might be a disaster because there are high chances of expulsive hemorrhage, uveal effusion syndrome, and prophylactic intraoperative sclerostomies are also debatable. So we thought, why not go for a non-penetrating deep sclerectomy surgery, which has got a higher safety profile than trabeculectomy. So CLASS is a modification of NPDS and has enhanced accuracy and safety, as the CO2 laser will be completely absorbed by the percolating aqueous after unroofing of the Schlemm's canal, protecting deeper tissues such as trabecular meshwork from the laser energy, and it also precludes sudden hypotony. This we published a series of 17 eyes of 17 patients in the DOS Times in May-June 2000.
Bring in Dr. Reena here.
And
because the net connection, we can't hear her properly.
Hello, ma'am, can you hear me? Hello, ma'am, can you hear me?
It's coming in spurts and breaking up. So we've heard the case, so we'll bring in Dr. Reena for the discussion. Yeah.
So, ma'am, the
Dr. Reena, are you here?
Hello.
Yeah, we can hear you.
Ajit, sir. Yeah, can I proceed, sir? So
Yes.
we want to conclude that this case highlights the importance of arriving at correct diagnosis by careful exclusion of other grave etiologies and the importance of non-penetrating deep sclerectomy surgeries in such scenarios. And we recently published this case report in IJO. So my queries and for my seniors, the questions for discussion will be, what is the role of netarosudil in this case, and it's why it's not available in India, so what should we do? Can micropulse laser cyclogy 6 give us some sort of short-term effect so that future trabeculectomy could be done? Would any MIGs be effective for such high IOPs? And are tubes the last resort, given that there will be hypertensive phase and macular snuff out can happen? Thank you so much.
Okay, Dr. Reena, are you here?
Yeah. So congratulations, that was a very nice presentation and an interesting case. And I think you rightly said key important things, that it's a diagnosis of exclusion. If you see a patient with high intraocular pressure and dilated episcleral veins, you rightly went through all the examinations and investigations required to rule out a possibility of arteriovenous anastomosis or carotocavernous fistula or any other reason leading to structural or obstructive lesion which was affecting the veins, whether orbital or intracranial. And I think that was ruled out. So an idiopathic elevated episcleral venous pressure diagnosis was made. Of course, in your case, the patient has had very advanced disease at presentation, which made the treatment a little more challenging. Whereas I've had only 2 such patients in the last 23 years, and both women and both bilateral but asymmetric, and they seemed to have done a little better because they were not so advanced on presentation. But I think rightly, as you said, trabeculectomy can be a little challenging and you can have a risk of choroidal effusions and hypotony and all. But even in your case, I think you rightly planned a non-penetrating glaucoma procedure, but I think somehow the penetration was deeper and it actually landed up becoming a penetrating procedure. So you reinforced it with a scleral patch graft to make sure that you don't have the complications which you were at first hand trying to avoid. But having become a full thickness procedure, again, it would have warranted a good follow-up to make sure that the patient did not have those challenging situations. Yes. But still, even in situations like in your case, sometimes you can have post-operatively choroidal effusions and all, so you have to be well prepared for it. And also, of course, the patient has to know. The AGV or a valve and all sometimes can be a little better because the post-op hypotony in those patients might be a little well controlled, especially if you've not had the tube opening. If it was titrated enough and there was no leakage around the tube, you can have a little more predictive outcomes in terms of how much IOP will get lowered in the first early post-operative days. So it's actually not a no-no. Coming to the possibility of using medical therapy, I'm not too sure. And anyways, it's not available in India, so I don't know what to say about it. But there are some reports that laser trabeculoplasty and all doesn't work in these eyes. So if you have to take them for surgical procedure, you are left with choosing either a non-penetrating glaucoma surgery like you did choose, or a trabeculectomy, but being very guarded, which means you want a tight trab. You might want to use a helon and leave it a little inside the eye to make sure that you reduce the post-operative complication chances. And a valve surgery can also be sometimes considered in some situations where you want to protect against hypotony in the early postoperative period. Rare, but this is something that we can see, and if we do, it's very important to rule out a possibility of a cavernous, carotid cavernous fistula or any other orbital pathology or thyroid ophthalmopathy or a tumor compressing onto the veins. So I think that goes without saying. A complete examination would be very, very important before you label this. I think that's what I'd like to say. If there's anybody else who would like to add something, but congratulations, that was a nice presentation.
Wonderful presentation, and thank you, Dr. Reena, for discussing it also in detail. In the interest of time, we'll move on to Dr. Devashish Chakravarti for his case presentation. Devashish, are you ready?
Yeah, good evening, everybody. A great thanks to Dr. Chandrima, Dr. Shurajit, and all the dignitaries associated with Kolkata Academy of Ophthalmology for giving me this opportunity. So I'll present a case of glaucoma in a child with Sturge-Weber syndrome. So the patient was an 11-year-old boy who came from the northeast, and he had the typical features of Sturge-Weber syndrome. He had hemangioma involving the right side of the face, including the eyelids, and he has been advised trabeculectomy elsewhere, and he had come for a follow-up visit. So he had dilated and tortuous episcleral vessels. The vision was 6/18. There was RAPD in this eye. The pressure was uncontrolled. It was 40 millimeter mercury with maximum tolerated medical therapy. Gonioscopy showed open angles with blood in the Schlemm's canal. There was 0.8 cupping with thin rims, and indirect ophthalmoscopy showed diffuse choroidal hemangioma. He had unreliable visual fields, and the B scan, as you can see, showed diffuse choroidal thickening. So as we know, Sturge-Weber syndrome is a non-familial sporadic disease. It is the most common phakomatosis that is associated with glaucoma, and it involves the skin and the eyes and the brain, and the findings are well known. I will not go into that. Glaucoma is associated in at least 30% of cases. Some studies have shown even more. And the most important thing about the glaucoma in Sturge-Weber syndrome is that it is associated with choroidal effusions or suprachoroidal hemorrhage, especially during intraocular surgery or if there is postoperative hypotony. What are the surgical options for glaucoma associated with Sturge-Weber syndrome? Early onset glaucoma is thought to be due to the pathology is goniogenesis, and the surgeries are goniotomy, trabeculotomy, and combined trab and trab, whereas late onset glaucoma is thought to be due to raised episcleral venous pressure, and here the surgical options are trab with MMC or glaucoma drainage devices. Now, there is always a dilemma between trab and tube when we encounter such a situation, because trabeculectomy has high risk of choroidal effusion and suprachoroidal hemorrhage, whereas Ahmed glaucoma valve is a good option in this patient. Because of the valve, the propensity of shallow AC would be theoretically slightly less at least. So we plan to go ahead with a Ahmed glaucoma valve pediatric implant, FP8, under general anesthesia, and the textbooks say ask us to take these precautions like a smaller size implants. That's why we used the pediatric size Ahmed implant, preoperative IV mannitol or on-table IV mannitol. Make sure that the closure takes place soon after the tube is inserted in the eye. Keep the graft trimmed and ready, and take as little time as possible after the tube is inserted so that you do not waste precious time. Then intracameral viscoelastic injection after the surgery to prevent post-op hypotony. Post-op cycloplegics may be prolonged for 3 to 4 weeks, and a close follow-up is mandatory. Now, I would present a very short surgical clip of the surgery that we have done. So for the sake of time, I would present it in the fast-forward mode. So we follow the usual steps. Because the orbit was a canthotomy, and then we do a conjunctival dissection, and we prime the Ahmed valve, put it inside the conjunctival space, then we suture the plate, enter with a 23 gauge needle, inject viscoelastic, then tie the tube with a 10-0 nylon and put a scleral patch graft fixed with glue, and then we close the conjunctiva with 80 micrel. Okay, so far so good. The surgery was uneventful, but The sad part was post-operative day 1, despite taking all the precautions, the AC was totally flat. The vision was only PL and PR, and the tube was sandwiched between the cornea and the sclera. Only the upper surface of the tube was visible. The tip was totally occluded by the iris, and the pupil was dragged towards the tube. There was peripheral iridocorneal touch, and there was no AC. The pressure was actually 30 millimeter of mercury because the tip was totally occluded by iris, and to top it all, there was 360-degree choroidal detachment. So we decided to go ahead with the conservative treatment. We put whatever the conservative treatment is mandatory. We frequent topical steroids and atropine and cycloplegics, and we also had to use dorzolamide timolol because the pressure was high, and we also gave systemic steroids. On day 2, the patient presented with a similar picture. The AC was flat, there was choroidal detachment still persisting, and we were thinking whether this patient would require a choroidal AC reformation. But we continued with the conservative management, and very fortunately on post-op day 5, you can see that the AC has started forming. The peripheral AC was only shallow, the central AC was formed. The choroidals had started resolving, and on day 15, to our great relief, the vision had improved to 6/36. The IOP had come down to 16, and the child was not requiring any anti-glaucoma medication. The AC was well formed, and the choroidals had completely resolved. This patient had followed up for more than 5 years, and the child is maintaining good IOP and stable vision, and he is requiring only one combination of dorzolamide timolol to control his IOP. My take-home message from this case is that a post-op shallow AC with choroidal detachment can occur after Ahmed glaucoma evolved in Sturge-Weber syndrome, even after taking adequate precautions. And even a flat AC can reform with conservative management without AC reformation. This is my experience from my subsequent cases also. And some authors have suggested that ligating the tube, even though it's a valved implant, if you ligate the tube like in a Marvelt or an Audi implant with a mitral suture, it can help prevent AC shallowing in such cases, even with Ahmed valve. And in subsequent 1 or 2 cases, I had followed this and I had found good results. So that is the conclusion of this case. Thank you once again for giving me this opportunity.
Thank you, Devashish. That was a great case. And Dr. Tutul, would you please discuss it? Are you here? Dr. Tutul Chakravarti, are you here? She's not here. She was here, but anyway, I think
she is there, but unmute. Yeah, she is there.
Can you hear me now?
Yeah, we can. Yes.
Yeah. So Devashish, is a wonderful case. I mean, very nicely you have just managed the whole thing. It looks like type 2 Sturge-Weber, and it's true that in early age for the children, angle problem is the main cause. This is a 60% cases, and that is venous pressure is another for the rest 40% cases, such as adult onset. Now, just I would like to know, I mean, now he is almost 16 years old, I believe, because it's under 6 years follow-up. So could you, I mean, now the question is we have to save this eye, and lifelong follow-up is needed. So could you, I mean, could you please share any visual field recently done just 2 years back or 1 year back, just 2 things, just to see whether glaucoma is progressing or not?
No, I don't have the visual fields with me, but his visual fields are stable. Whatever damage was there, that has not progressed, and his pressure he's also maintaining good IOP, only with dorzolamide timolol combination.
Yeah, because IOP is not the only marker to see whether the glaucoma is progressing or not, because from the age of 4 to 16, 17, IOP is just like from 4 to 10 is gradually, decreasing, and this is again from 11 onwards, this is increasing. So IOP is not the marker, but perhaps we can follow up the case with regular visual field. And secondly, why it is used only dorzoxtimolol? I mean, is there any special reason that is you are not using latanoprost in this case?
No, initially what happens is after Ahmed valve, there is a hypertensive phase. Although in this patient there was a choroidal and initially tube occlusion, but after that, in order to reduce the hypertensive phase of Ahmed valve, we always use an aqueous suppressant. So in case of children, dorzolamide timolol is a safe combination. It will reduce the aqueous, it will prevent the hypertensive phase, and the pressure had been maintained on this combination, so we didn't want to change it.
Of course, I don't know. I mean, whether because if the Dr. Mandal could have
we have a comment from Dr. Mandal. Is here?
Yeah, Dr. Mandal, this I mean, which one will be most safest here for post-operative period? I can't hear.
Dr. Mandal, are you here?
He has to unmute himself.
Yeah.
So please unmute yourself, sir.
Yes.
Yes, sir.
So there was this very well managed case. The question of drug of choice in this situation, I think topical acetazolamide and beta blocker combination is I'll choose as the first option, because on Sturge-Weber syndrome, the pressure lowering effect of prostaglandin is controversial. Sometimes it doesn't give good effect. That's the situation. That's the reason dorzolamide timolol combination is a good one.
Can I make a comment, Dr. Chandra?
Yes, please.
Yeah, so, well, the Sturge-Webers that we've seen, especially, I think the choroidal detachments, one thing is that they are most troublesome in the second wave. We don't see choroidal detachments or effusions when we do it in very small babies in the congenital variety. Probably it's because the sclera is more expansile and there is some leeway of the fluid to go out rather than go in. So that's one. And secondly, we've used propranolol. We've just published our results in ophthalmology glaucomas. You can go through it. And we used to be very, very troubled with choroidal effusions. And one message I can give is that even for post-operative choroidal effusions, even if you haven't given it pre-operatively, post-operative propranolol also works very well. And the idea has come from propranolol being the drug of choice for infantile hemangiomas, for nasopharyngeal hemangiomas, and so we extended its use to the choroidal hemangioma of Sturge-Weber. I have yet to see a Sturge-Weber syndrome with glaucoma without a choroidal hemangioma. Another tip is it's a diffuse choroidal hemangioma. It's not a circumscribed orange mass which is described. And if you do an indirect, you must do it with dilated both eyes, and that's when you'll see the tomato ketchup appearance of this particular eye, and invariably an ultrasound will show choroidal thickness. So what propranolol does pre-operatively or peri-operatively rather is involutes this hemangioma a little bit, and we give it a 2 milligram per kg, and we touch wood till date haven't seen choroidal effusions after that. So it's just one small tip. It's a safe drug to use, and I'd be happy to share the paper with anybody who wants to, but it's available in ophthalmology glaucoma this year.
Thank you, Shushmita. Is there anybody else who wants to add anything, or else we'll move on to the next case? Yes, please. Dr. Mariam, you want to say something?
Yeah, there is a annular detachment. No, there is a choroidal detachment. Then why there is a tension is low or high? It is 30 millimeter of mercury.
Yeah, because the AC was completely flat and the tip of the tube was occluded by the iris. That was causing the high IOP. So once the AC started forming, then the pressure came down.
But I think if tube is closed, even then tension must be low in the initial stage. And in the Sturge-Weber syndrome, the suprachoroidal hemorrhage is more common compared to the choroidal detachment. So that's why they do the sclerotomy to avoid this choroidal hemorrhage. I think so.
Sclerotomies have been suggested by some authors, but it has also been suggested that most of choroids that occur in Sturge-Weber syndrome, they resolve spontaneously with conservative management only. So the question of doing an invasive procedure for something which usually resolves spontaneously, that creates some doubt.
No, I am also doing without sclerotomy, this trabeculectomy. In this Sturge-Weber syndrome, there is no suprachoroidal hemorrhage or nothing, but it is said that suprachoroidal hemorrhage is more common compared to this choroidal detachment.
So we move on to the next case then, the last case of the evening, Dr. Anuradha.
Is my video visible?
Yes, yes.
So I thank you, ma'am, for giving me this wonderful opportunity to talk about the STAR faculty. So my case was a aniditic glaucoma, 2-year-old child who came presented to us with a severe photophobia. The pressures were 30, 34. So we decided for a limbal approach in this child because cell deficiency. As you can see, I have used a MMC of 0.04 milligram for 1.5 minutes, and then we made a rectangular flap in this patient. We have to be very careful because at this step you can go too deep or too shallow. In either cases, you can have problems. And we are doing the Schlemm's canal now. And as you can see, initially the gray area is the area where we need to do this. And once the Schlemm's canal opens up, you can we can use a trabeculotome to enter. But as you can, this patient had a posterior embryotoxin with partial aniridia, and the area where the iris was present, the trabeculotome was not able to go completely inside. So I would ask my discussant to discuss about this because I have found few cases where these are a problem and the Schlemm's canal is not completely developed in these aniridic eyes. The next is we do a trabeculectomy in this eye and we put a single N0 nylon suture in this for the at the apex, and we form the other thing we do is we use a 26 gauge needle and with air, and we don't make a side port. So that was the method Dr. Ramanjit Sivata used to teach us. So that would be another thing we would like to discuss in this case. And after we close the suture, close the conjunctiva with 80 Vicryl, and we use a continuous suture in this patient. Once the surgery was done, we saw that there was a free flow of water from the anterior chamber into the blood. After surgery, the first post-op day, the child had no photophobia and the eye was quiet, and the pressures were done after 1 week and the pressure was 10 and 12. Unfortunately, this was done in February, and in March the follow-up was decided, but the patient could not arrive from Bihar because of the lockdown. So I have very limited follow-up of this patient.
Thank you, Anuradha. That was beautifully done. And Dr. Ravindran, would you please give in your comments?
Yeah, am I visible now?
Yes, you are.
Yeah, a very rare case actually. For me, I have not seen such aniridia cases, and so I would require support from senior faculty. So what I have understood is that we have used MMC in this case.
Yes, sir.
But because of the limbal stem cell deficiency, I think there is a good option of using Ologen in these cases. And regarding the second,
so you are muted.
You have to unmute. Unmute.
probably do is the right time of surgery. There has been a suggestion in literature that if we are able to longitudinally follow up by gonioscopy, then at a particular time when the angle is really getting obscured, we may be able to time our surgery and rather do a preventive trabeculotomy also. So that is something that has been described. Probably it is not possible in our situation. This is really our country, and our people's follow-up will not be so good. So talking of being realistic, whatever is best possible has been done. And what was the other question? I think the job of retaining the vision in these cases with the IOP control is only half the job done. Later on, we have to give low vision aids and contrast modifying spectacles, and probably the visual acuity will be low, and so magnifying aids will also be required.
Yes, sir.
And those were my points. The senior faculty may be able to add many more points.
Yeah. Could we have Dr. Anil Mandal, please, to comment on this? Dr. Anil Mandal, if Dr. Vijaya ma'am is there, Dr. Vijaya ma'am also, and RK sir is probably not there. Yeah,
RK sir is there, muted.
Oh.
Okay, so one comment about aniridia is, interestingly, we actually saw a baby where on fundus evaluation on EUA, we couldn't actually see the foveal reflex.
Yes, ma'am.
And but there was no aniridia. The iris was there. And when we reviewed literature, just one point to make, that about 7 to 9% of cases of aniridia may have an iris. So it's aniridia complex. The aniridia complex is aniridia keratopathy, limbal stem cell deficiency, foveal hypoplasia, and varying degrees of iris hypoplasia. So that was a learning for us, and this is called a PAX6 syndrome actually. So PAX6 is the gene, but remember that PAX6 is something like a regulator gene which controls so many parts of the anterior chamber that the iris may well be developed but a little hypoplastic, and yet there'll be aniridia. I think the learning point for us was vascularization at the limbus. See a pannus in a baby, look for PAX6 syndrome, and then look for foveal hypoplasia, look for nystagmus, and you might be dealing with aniridia without complete aniridia as well. That's the only comment.
There may be ectopia like this also in this patient.
Yes.
I have seen one patient.
Yes, ma'am. It is reported that they have weak zonules. So zonulopathy is also present in aniridic patients.
Do we have Dr. Mandal for his comments?
Ma'am, another thing in aniridia I read about is ataluren. This is one of the new gene therapy which they are thinking about, where the protein formation is improved and children are improving. They have good reading capacity in children who were earlier having problems. So that is another.
Maybe I can add a couple of points. So the questions that you had asked, Anuradha, was do we form the anterior chamber with air at the end of the surgery? You had done it, which is a good idea. So was there a question related to that?
Ma'am, actually
so sometimes
using
we
the
also
needle.
Yeah, needle, yes.
Yes.
So we also do this, especially in situations where you don't want any amount of hypotony in the eye, and in conditions where reforming the anterior chamber with saline is not going to help. For example, in microspirophakia, suppose we have in these eyes, shallowing is inevitable, and that is the reason why we use an air bladder. And I think Dr. Mandal has very clearly shown, and we have a beautiful video that actually can demonstrate that. But we use a 29 or a 30 gauge needle and make a track which is almost like a 2-step or a 3-step track. Because in kids we need to realize that any
is a problem.
Parasiticides that we do with 29 gauge, we still are very skeptical, and we do take one suture with a 10-0 nylon. So even if you're using a very small gauge entry, always make sure that that is closed. And because it is a nylon suture and they can loosen, we need to take the baby up for an EVA in a couple of weeks to remove that suture, because otherwise suture related infections are very common, because once the pressure goes down, the suture loosens and you may have a problem. So that is the only point I wanted to make. So we can use air, especially because there's no iris, and lenticular corneal touch in the early post-op period is a concern. It definitely helps. But because the iris is not there, we need to be very, very careful in doing an anterior chamber entry, because we can hit the lens otherwise. Okay, so these are the two points. The other thing, when you were trying to do the deep block, we saw there was a little bit of bleeding, and because
Yes,
there was
ma'am.
partial aniridia, this was actually a partial aniridia. Iris, and one side was mostly absent. So unless we see a stump of a large iris stump, which is there close to the deep ostium, which is kind of blocking your deep ostium or the fluid filtration through your deep ostium, we can actually avoid doing an iridectomy, because that little stump, if they are tiny little stumps and they are allowing the fluid to filter, you don't have to pull them, because that is the root of the iris. If we go and deal with it, they may start bleeding terribly. Another thing that we do when we have a very small stump and you're not able to excise it is we use a gentle cautery. So you can use the just like the regular cautery that we have. Ask the assistant to keep putting some saline there, and we use very gentle. Even otherwise for trab and trap, we use a gentle cautery to go and coagulate those long ciliary processes that are there. If you do that, you realize that your filtration is much better, and these ciliary processes don't come and come into your ostium and block the ostium. So this is one small modification. So this cautery, bipolar cautery, but underwater.
Ma'am, another thing, whether you would have preferred a goniotomy as a first thing, because the patient had a posterior embryotoxin in this case.
So goniotomy may be helpful if the angle is open and it is not closed with the iris stumps synechially. Otherwise, I don't think it works. And just like Sturge-Weber's that we discussed, that you can have two groups of cohorts of patients where you have glaucoma in a very young versus glaucoma in older children. Aniridia, glaucoma in older children is extremely difficult to treat, and they are associated with a lot of complications where they have ectopia lentis, where they have significant keratopathy and things like that. But very young children who develop glaucoma in aniridia, again, they have angle dysgenesis, which also could be a major part, because sometimes they are born with glaucoma also. So it's not the older children where you have a progressive angle closure, but it is the dysgenesis that is causing a very early glaucoma. There, in those eyes, actually the outcomes are quite good. The older they are, again, it is difficult and complications are higher.
So if I might just
add, and I agree with you, a limbal-based approach is something that we would also prefer, because you want to avoid touching the limbus and the stem cells in that area.
So just to add on to that, it's David Walton who propagates prophylactic because he believes that come what may, these children are going to go on and develop glaucoma even if they don't have it now. So this is David Walton's theory that if you catch them young and you open up their angles, you might actually obviate the development of very intractable glaucoma later rather than wait for that to happen. So that's a thought, though you have to have a lot of jigger to do goniotomy in these children with no irises.
Yes, ma'am. Thank you.
Absolutely. So is there any other input? I think Dr. Vijaya and Dr. RK are both muted.
I think I want to ask a question to Sushmita. If goniotomy is, if it is going to prevent a further problem in future, why not a trabeculectomy will work?
It will, ma'am. Any angle surgery.
Yeah.
It's just
I just wanted to bring that highlight.
With the limbal stem cell deficiency and everything, we would like to avoid opening up the sclera and vein in that area. So maybe that's why a goniotomy, but with the same mechanism, it should be the same.
And the limbal cell deficiency to happen, so if you are contemplating a goniotomy, it is going to be very, very early, not when they are big enough. Yes. So that stage, I think, if you are cautious enough in opening and closing, and the limbus is still healthy, probably you may not cause damage.
And ma'am, the goniotomy can be done clear corneal, so you can avoid the limbus.
No, because of the aniridia, if somebody is not comfortable in doing the goniotomy, because damaging the lens versus the possible limbal problem.
Correct, ma'am.
It's worthwhile if somebody is comfortable with the trabeculectomy to do the trabeculectomy rather than the goniotomy.
So,
so I'm just looking at the limbal cell deficiency versus the possibility of lens damage.
Any other input? That was a very rich discussion. Any other input? Or else we'll wrap it up. So I'll hand it over. Thank you very much, everybody.
Thank you, ma'am.
We really had brilliant talks and wonderful discussion. And I'll hand it over to the organizing secretary, Dr. Rajesh Mazumdar Chaudhary, for the vote of thanks.
Thank you, Chandrima. Ladies and gentlemen, a healthcare delivery system which is empathetic, which is ethical, and which is evidence-based is a fundamental right for the citizens of all civilized society. And I must say with pride that members of the Kolkata Academy have been striving for a long time to provide that kind of therapy through their patients and their clients. And it is not amiss to say that Kolkata Academy has provided the academic template for them. I thank you all your, all the superstars and the superheroes that we have here for being our co-travelers in this evening for a few hours. It's time also to blow our own trumpet, because I must thank the executive committee members, especially Dr. Chandrima, Dr. Shurajit, and Dr. Shumit for putting up this wonderful program for all of us who are not glaucoma specialists. Things have been so lucid that even I could understand a little bit of what was going on. Obviously, thanks to Santon for providing the logistical support. And it will be amiss, again, not to thank Ms. Chetna and Mr. Puneet for their fantastic technical support. So, ladies and gentlemen, it's time to say Shubharatri, Shabak Khair, and good night. But with this hope and wish that we see you soon when this time's over and we host you physically in Kolkata. Thank you again for your patience.
Thank you. Thank you very much. Thank you.
Thank you.
Thank you.
Thank
Thank you, everybody. Good night.
Good night.
Thank you. Thank you. Good night.
Thank you. Thank you all. Thank you. Good night.
Thank you.
Here,
Thank
sir.
you. Good night, sir.
Good night, sir.